Good morning, everyone. We're live.
Awesome. Well, good morning, everyone. Today we have two committee meetings back to back. First is Market Oversight and Transparency Committee. Will go until 11, and then we will pass the meeting along to our colleagues. We'll have a sort of a great look at lots of issues that we're doing here. So it's my pleasure to welcome everyone, including I think I saw Deb. Did I see Deb? No, I didn't see Deb. I thought I had, but this is our first meeting with her as our chair, so I'm excited about that. Well, why don't we start off? In a second, I'll turn over to David to walk through the agenda, but I think the first item on our agenda is always to approve the minutes of the previous meeting. So let me, I know we've all been sent that, so let me first see whether anyone, I guess first we need a motion to approve them and then we can discuss the meeting. So does anyone want to offer a motion?
So moved.
So moved.
Okay, and any seconds for them?
Second.
Okay, and so now I suppose the question is, do we have any discussion? Anyone want to discuss or add or subtract? Okay, if not, then then I believe we need to do a roll call vote. Is that correct? Because we're still on Zoom. Is that correct?
That's correct, and I'll be happy to help lead the roll call vote this morning. So we'll start with you, Commissioner Cutler.
Approve.
Commissioner Roeder.
Approve.
And Commissioner Mastrogiovanni.
Approved.
And I believe that is it for members of this committee. We are joined by Commissioner Cohen and Commissioner Blakeney. Thank you for joining this meeting as well, but we do have the votes to approve the minutes.
Okay, excellent. So we have a couple of actually really exciting things today. David, maybe I can turn it over to you to give us a introduction to them and then lead us into it.
Great. Thank you, Professor Cutler, and welcome everyone. Good morning. We're excited to be here this morning for, as Chair Cutler said, back-to-back committee meetings with just a lot of interesting topics. And we really wanted to build these meetings kind of building off of the board meeting recently where the board approved policy recommendations in our annual cost trends report and wanted to revisit a number of the topics that were included in those recommendations and in that report. One of the areas that we had looked at in this report, in the cost trends report, was the impact of the COVID-19 pandemic on different use of care and setting of care. And in addition, the legislature had asked us to do a much deeper dive on utilization of telehealth. And so we're going to be presenting a pretty lengthy research presentation here this morning. This is the first time that we're releasing these findings publicly. And so as a result, we really are hoping for your questions, your comments, your feedback, because this will go into a final report to the legislature early next year. So this is really kind of the first glance at this incredible work. And I just will praise the team here who utilize some really novel methods of claims utilization to try to understand the use of telehealth during the pandemic. Of course, there are significant policy considerations to this topic as well, and hope to get the commissioner's feedback on that. The second major agenda item will be again, reflective of one of our policy recommendations in the cost trends report around the need to address price variation and also relatedly to have greater oversight of provider expansions. And so there have been a number of recent provider expansions that have been proposed. And so want to provide an update to this committee on some of those expansions and what we found to be some of the dynamics that may drive concerns or mitigate those concerns of those expansions. And then finally, we will just provide a brief update to the committee on regulatory changes that we're going to need to make to the Office of Patient Protection as a result of recent legislation passed this summer on the expanding mental health benefits and parity. So those are our three main topics. I'll turn it back over to you, Chair Cutler. or else we can start to dive right into the telehealth.
I think we can dive right in. I'm looking forward to it.
Great.
I suppose since we're on Zoom, we should just, if people want to jump in like for questions while the presentation is ongoing, just do so in whatever fashion. And then at the end, we'll obviously have time for lots more discussion.
Perfect. Sarah.
Great. Good morning, everyone. We are very pleased to to present our work on telehealth on our report that is in progress, and to share some new and very exciting preliminary results. So next slide, please. So telehealth, as many or probably most of us here have had personal experience with, is a rapidly changing landscape that that really developed as a response to the COVID-19 pandemic. There were a number of temporary policies that were put into place to bolster this new modality. And those include, starting from sort of the earliest emergency order about from the Baker administration mandating coverage of telehealth, as well as sort of one of the key questions that will come up again and again is what should the reimbursement be with respect to in-person services, and that emergency order mandated payment parity with in-person services. The next piece of legislation required payment parity with behavioral health services in perpetuity, and set payment parity with in-person services for primary care and chronic disease management, but with an expiration date of this coming January 1st. So there are a number of questions that remain around what these policies should be going forward as some of these sunsets come into view. Next slide. So in light of those questions, the HPC was charged by the legislature with a report to answer some of these key questions, and in doing so, to capitalize on the data that is just kind of starting to become available on user experience with telehealth and payment in Massachusetts. So we are charged with analyzing use and spending associated with telehealth by payer, provider organization, by patients, geography, a number of key questions. We know that one size does not fit all. Assessing patient access and quality, and a number of important questions there, and finally providing policy recommendations on on what those reimbursement levels should be, and a number of sub-questions, and really how to tie together payment quality and access, and ways to really kind of keep this market strong moving forward. So we're going to go through today our preliminary results on some of these key questions, and then return at the end to talking about sort of stakeholder input and the policy considerations that we see as most most prominent. So for our discussion of our results, I'm going to turn this to my colleague Yua Wang. Yua, take it away.
Good morning, commissioners. Can everyone hear me okay? Great. So today I'm going to focus my presentation on our commercial results. For the final report, we're also hoping to include some big picture trends from our MassHealth ACO data, but today we'll be talking about results from our all-payer claims database. So I'll talk through the methods and data source here quickly. So for this analysis, we use the all-payer claims database, which includes 5 large commercial payers, We included professional and facility claims. I'll just say up top, because I think this question will come up. We do see some facility claims for telehealth, but the number is pretty small. Within all telehealth claim lines, about 3.5% were for facility claims. So they're in here, but compared to professional claims, the volume for telehealth facility claims is pretty small. And for the most part, claim lines on the same day for the same person in the same site were combined into one visit. And we restricted our sample to commercial members under 65. To identify telehealth, the methods is similar to previous bodies of work that we've published. We identify telehealth using 3 methods: the place of service code, number 2, a number of procedure modifiers, and a list of telehealth specific procedure codes. And for this analysis, we are not looking at remote patient monitoring and chronic care management codes. Okay, next slide, please. So first we'll start off with overall use of telehealth services in 2020. So here are some big picture trends going back to 2018. So you can see here the share of ambulatory visits by site. In 2018 and 2019, really the vast majority of ambulatory visits happened in the office and hospital outpatient setting. So 93% in both years. And then in 2020, the volume of telehealth really grew. And you can see in the third bar on the right that telehealth made up about 1/3 of all ambulatory visits in 2020. And I have these figures on the right-hand side, which shows that the share of commercial members in our sample who had any telehealth use was less than 1% in 2018 and 2019. And then in 2020, this number shot up to over 50%. So this is really paradigm shift in terms of the growth of telehealth and the way people used healthcare. And next slide, please. And in this slide, we zoom in on 2020, and here people have probably seen this version of a graph a few times. So here we combined office, hospital, outpatients, urgent care center, retail clinics, etc. All these sites into this category we're calling in-person care here. And we compare that against the volume of telehealth visits. So you can see here in March, starting in March, the total visit volume started to drop pretty dramatically at the onset of the COVID-19 pandemic. But at the same time, telehealth really started to ramp up. And the percent of ambulatory visits that were telehealth peaked in April and May, where the share of visits that were telehealth are about over 60%, about 60%. And then over time, the percent of visits that were telehealth started to drop a little bit. And towards the end of the year, their share is about 30% or so. So this made us wonder, for what type of conditions do people continue to use telehealth for? And for what type of conditions did people start to go back in person once they've had the option to? So on the next slide, we broke this down by condition, and you can see here that it's really mental health where the high telehealth use is sustained. So the line graphs here show the percent of ambulatory visits that were delivered by telehealth on a monthly basis, and you can see for mental health conditions, 80% of the visits were telehealth all through the end of 2020. And in comparison, for non-mental health conditions, telehealth use sort of peaked in April at over 50%, and then it gradually dropped down to 16% towards the end of the year. So let's then look at these conditions in some more details. On the next slide, here, this is perhaps not surprising. 63% of all telehealth visits were for mental health conditions. That's the blue box. And the second largest category, which is magnitude smaller, this is for symptoms, signs, and abnormal findings. So these are things like where the diagnosis is fever, rash, cough. And the third largest category is for musculoskeletal conditions at about 4%. And for all other conditions, their telehealth was 3% or less. And how does this compare to in-person office visits? So that's on the next slide. So here we compare telehealth and office visits by clinical areas, and we do see some differences. So for example, the orange segment of the bars here are musculoskeletal conditions. So these are things that might be for back pain or osteoarthritis or physical therapy. You can see here that for these conditions, they were still largely conducted in person in 2020. About 20% of office visits were for these types of conditions. And the yellow portion of the bar are for routine exams with no abnormal findings. So these are sort of your preventive wellness exams. You can see these were still largely conducted in person. And for mental health, again, we said earlier that 63% of telehealth visits were for mental health versus in the office setting, 16% of office visits were for mental health conditions. So, okay, and then moving on. So here we continue to compare office and telehealth visits, and here we looked at the reimbursement levels. And in this graph, we are showing you the average payment for a set of psychotherapy codes, and we looked at their average payment. So this includes how much the payer paid, as well as the patient cost sharing. And you can see across these 6 codes, telehealth and in-person services were paid at roughly the same rate. And this is consistent with the payment parity mandate that Sarah talked about earlier. And then we looked at cost sharing, and here there was some differences on the next slide. Here you can see that for telehealth, payers generally waived cost sharing in 2020. And in comparison, there were still cost sharing for many patients if they wanted to see their therapist in person in the office. And I will say, like, I'm only showing the results for psychotherapy here, but we did look at other services, for example, evaluation and management services, and the finding was the same. Reimbursement levels were consistent. We'll talk more about cost sharing on a later slide. Okay, next. So next, we'll talk about some areas where there are variation in terms of telehealth services. So first, we looked at this by payer. And the bar graphs here show the percentage of ambulatory visits that were telehealth by payer and by quarter. And you can see this is for all 5 payers on our data: Blue Cross, Blue Shield, Harvard Pilgrim, Always, Tufts, and Anthem. The percent of ambulatory visits that were telehealth was really similar over time. And next, we'll look at geographic variation. So here we're focusing on members who had visits for non-mental health conditions. And what we're showing you here is the percent of members who had any telehealth use for these conditions by zip code. And you can see here that in our state, telehealth use for these conditions was higher for residents in the Metro Boston area and higher for folks living in the Pioneer Valley and Franklin region, and a little lower in the middle part of the state. Next slide, please. And then this is still focusing on people who had utilization for non-mental health services. Here we looked at variation by provider or organization. And you can see that there's significant variation by provider org here. On the left-hand side, we have MCIPA, Beth Israel Lahey, Atrius, and MGB, where the percent of members who had any telehealth use for non-mental health conditions was about 60%. And then on the right-hand side, for members attributed for Reliant, for example, the percent of members with telehealth use for these conditions was 37%. Okay, so here we talked about members who are seen for non-mental health conditions. Here we look at members with mental health conditions. And unfortunately, we're not able to look at every zip code here. In some cases, the sample size was too small, so those are the gray areas. But we know from the few earlier slides that telehealth use for mental health, it was high overall. So you can see right off the bat, this is a darker map. Telehealth use is high everywhere. But still, there's some variation. For example, again, in the central part of the state and the western part of the state, telehealth use was lower. And next slide, again, looking at folks with mental health conditions, but looking at variation by provider organization. And here, there's still variation, but the variation is much smaller. By provider org, use of telehealth is high for mental health conditions. Okay, so next, putting all these factors together, we talked about geography, we talked about provider organization, mental health history, and other demographic factors. We put everything into a regression model, and this is our best attempt at making regression easy for folks to understand. So the orange dots are the effect sizes, and the brackets around them are the error bars. For some of these dots, it might be a little hard to see the error bars or the confidence intervals, sorry. It might be a little hard to see them because the confidence intervals are actually quite tight. So I'll talk through the first variable, having had a mental health visit here, to walk you through how to interpret these results. So for the top, the dot on the top, the way to read this is, if you are someone who has had a mental health visit, you are 35 percentage points more likely to have been a telehealth user compared to someone who's not had a mental health visit. So this makes sense based on our earlier presentation. Folks with mental health conditions use a lot more telehealth. So okay, we'll walk down the list of variables here. Next is age. The older you are, if you're older, you tend to use telehealth more compared to people under 18. If you are female, you're slightly more likely to use telehealth. If you have higher risk score, you're more likely to use telehealth. And then next we have community income quintile. I think the results here are a little unintuitive. People tend to assume people living in higher income areas might use telehealth more, but I will say here, in the raw results where we looked at percentage of members with telehealth use by community income quintile, the percentages were really similar. They're within 1 percentage point difference between these income quintiles. But here it appears that after adjusting for a few factors, those living in higher income quintiles actually use a little less telehealth. But I would add that, in this model, in order for us to categorize you as a telehealth user or someone who's only had in-person visit, you need to be someone who had utilization in 2020. And we know based on our ambulatory work in the cost trends report, folks living in lower income communities were more likely to not have any medical spending in 2020. So those people are not in this model. So I think that might explain some of the results here as well. I would say overall, I would interpret this as there's minimal difference in terms of telehealth by community income quintile. And then next we have geography. It looks like for folks living in urban areas, they tend to use telehealth more. And then lastly, we have community internet access, which is measured by percent of households with an internet subscription. The better community internet access you have, the more likely you are to be a telehealth user. And I'll add that community internet access here includes folks who have a cell phone data plan. Okay, And on the next slide, so the regression continues. Here we have the provider organizations. So this is pretty similar to the raw results I showed earlier. And here it just shows that even after adjusting for differences in their patient population, we still see variation in terms of telehealth by provider organization. You know, on the right-hand side, Atria's, Beth Israel-Lahey, MCIPA, MGB had some of the highest telehealth used by provider organization. And then on the left, we have Reliance, South Shore, and UMass, where telehealth was less for its members. Okay, next slide, please. Okay, so next we return to the topic of cost sharing.
You up?
Yeah. Oh, you're muted.
Sorry, can you just return to that last slide on variation by provider organization? So you had showed earlier that the variation in telehealth use by provider organization there was more variation for non-mental health telehealth use among the provider organizations. And when you looked at mental health utilization by provider organization, there was much less variation and kind of high rates across the board. So are this variation in this model kind of reflective of non-mental health telehealth related use by provider org, or is there other dynamics that I should be aware of here?
This is sort of an average of the two. This is, we put everyone in the model. Some of them had mental health. Some of them had utilization for mental health. Some of them used telehealth for other conditions. This is all together, and we adjusted for example, on the earlier side, we adjusted for age and gender and risk score. So this model sort of adjusts for the differences in these provider orgs patient population, and we're still showing that there is variation. So you're right, the variation, I think, largely comes from the non-mental health conditions, but this is sort of, I consider sort of an average effect.
Yeah, I just find this so fascinating because, you know, just looking through this, it's not apparent to me that there's a clear pattern here. You know, there's, you know, physician-led organizations like Atrius and MCIPA, which are on one side, and physician organizations like Reliant that are on the other side. There are, you know, hospital-based systems and systems kind of across the Commonwealth. So, you know, would love to understand more about, for the provider organizations that had lower use of telehealth, was that they weren't offering those services via telehealth, or, you know, maybe we can talk to a few of these people and understand a little bit more about what might be driving this variation.
Yeah, certainly. These are certainly topics that we're hoping to get a better understanding of through our stakeholder conversations, and just based on conversations that we've had in the past, it's really clear that this is the use, how to provide patients with telehealth and what type of conditions are right for telehealth. All this has been a learning experience for providers over time and for patients. I think many of us might not have had experience using telehealth at the beginning of the pandemic, and then over time we learn what is the right condition for telehealth. And so these things are changing perhaps over time, and definitely an area that we hope to keep monitoring once we have the 2021 data as well.
So in some other national data that I've been looking at, one of the characteristics associated with more rapid and greater use of telehealth is being an academic medical center. And we're seeing that a little bit here too, in that BI Lahey, BMC, MCIPA, MGB, Atrius, I think all have an academic affiliation. UMass, of course, does as well, and it's not particularly high, but on average, academic affiliation ones seem to be a little bit more into telehealth.
Yeah, it's interesting that the central mass phenomenon here too, where geographically we noted that there was less telehealth use in that region, and the providers that serve that region tend to be on a little bit on the lower side as well. And so is that something about you know, the demographics or geography in that region, about how care patterns have usually existed. Is it something about the providers? So there's a central mass connection here too.
Right. Okay, great. So let's continue, and we are going to return to the topic of cost sharing. So here I'm showing the percent of telehealth visits that had any cost sharing by month, and you can see here, you know, in March, pretty much all 5 payers in our data waived virtually all cost sharing for telehealth for the first 6 months of the pandemic. And then in October, Harvard-Pilgrim reinstated the majority of cost sharing for the telehealth visits that we can see in the data, and Anthem reinstated a small share of cost sharing for a small share of cost sharing for telehealth visits, and the other 3 payers continue to waive cost sharing for nearly all telehealth visits. So this creates kind of an opportunity for a natural experiment here to see how cost sharing affects utilization. So that's what we did on the next slide. Here we looked at 2 sets of services that were common. We looked at, on the left, we have psychotherapy, and we here show you the number of telehealth visits per 1,000 people. The number of psychotherapy visits, the number of psychotherapy telehealth visits per 1,000 people. And we know from prior work that the volume of psychotherapy went up over time in 2020. And you can see here, this is true for all 5 payers. The number of visits went up in the last quarter. And the theory is that if Harvard-Pilgrim reinstating cost sharing reduces demand, you would think that the number of visits wouldn't go up as much for Harvard-Pilgrim. And you see on the left that's not quite the case. It's sort of on par. The volume for psychotherapy went up on par as 2 other payers, and not the largest. And on the right here, we have non-mental health evaluation and management services. And here for all 5 payers, the number of telehealth visits went down. We saw in earlier slides that for non-mental health conditions, once folks had the option to go back in person, telehealth volume dropped. So this is true for all 5 payers. And again, you would think that if cost sharing reduces demand, Harvard-Pilgrim would have the biggest drop in utilization here. And that does not appear to be the case. And then on the next slide, we looked at telehealth spending. So this includes psychotherapy, non-mental health evaluation management, and other telehealth services. And again, if we think that having cost sharing reduces demand, we would expect to see spending dropping the most for Harvard-Pilgrim members. And again, this does not appear to be the case. The reduction in spending is similar to Tufts and smaller than Always, and slightly larger than Blue Cross and Anthem. So I will say the caveat here is there were a lot of moving variables during the COVID-19 pandemic, and payers were assessing the situation and developing their policies. And it's possible that as a member, you might not know at the time your cost sharing was waived from this time to this time, and it was reinstated in October. So members may not get the signaling effect from the cost sharing. So certainly it's an area we want to keep monitoring once we have 2021 data. But so far, data from the last quarter of 2020 suggests that cost sharing does not appear to impact telehealth spending. Okay.
I could imagine another hypothesis here too, which is that for patients who had been receiving psychotherapy telehealth visits, their option would be to go back into office and pay a copay, or to continue on telehealth and pay a copay.
Right.
and that their positive experience of the telehealth modality led them to say, I'm just going to keep doing this on telehealth. Or, I think one variable would be, did people discontinue? And maybe we'll need a little bit more data
Mhm.
to understand that.
Right. And I think that is true. I think there has been a number of research papers that have come out based on surveys and other methods that say patients really like telehealth, and especially for mental health conditions, they really feel like telehealth is sort of analogous to in-person visits and offers a number of other benefits, such as not having to travel to a provider's office. Okay, so the last bucket of analysis I'll present here, it's looking at telehealth's effect on total spending. And you can go to the next slide, please. And the research design here is a little bit complicated, so bear with me as I walk you through the research design here. So we know telehealth became a lot more available in 2020, and we know that telehealth use went up a lot in 2020, but we also know that spending dropped for almost everyone in 2020. And so just observing that spending went up and spending went down and telehealth went up doesn't quite give us the answer that we want. So what we ended up doing is to create sort of a randomized experiment by comparing how utilization and spending changed for people with greater telehealth access and adoption versus patients with less telehealth access and adoption, who are otherwise pretty similar, clinically speaking. And on an individual level, we don't know who has better or worse access. So we created a proxy for this. We looked at areas with higher telehealth use and areas with lower telehealth use. And we sorted patients into this high telehealth group and a low telehealth group based on where they live. So on the next slide, I go into some more details on how exactly we did this. So we took routine E&M visits. These are evaluation and management visits that are not for mental health conditions. And we looked at what percentage of these visits were delivered via telehealth at the zip code level. And on the right, we have this table that shows you, so we looked at this on the zip code level, and then we sorted these zip codes into quartiles. And on the right, we have this table here that shows you in the lowest zip code quartile, the percent of routine E&M visits that were telehealth was 19%. And then in the highest zip code quartile, so that's number 4, the percent of E&M visits that were telehealth was 34%. So there's quite a bit of variation. So now we have the lowest quartile areas with low telehealth use and adoption, and this high telehealth area, the highest quartile. And we sorted people into the high group or the low group based on the zip code they live in. And we know because the utilization and spending patterns can be really different for people with different health conditions. We also created cohorts of people. So this is on the next slide, where we created 3 cohorts of people who are all similar clinically within the cohort. So we have the cardiometabolic cohort. These are adults with cardiovascular disease, diabetes, or hypertension. We have the asthma cohort, adults with asthma. And we have a healthy cohort. These are people who had no chronic conditions and have a low risk score. So within each of these cohorts, we have a high telehealth group and a low telehealth group. And next, I'll walk you through those results to see how their spending and utilization changed. So here are results for the cardiometabolic cohort. And on the left, we have people who live in zip codes that have lower telehealth use overall. And we can see that their total number of ambulatory visits dropped from 2019 to 2020, from on average 17 visits to about 15 visits. And within those 15 visits, 2.5 were telehealth and the rest were in person. And on the right, we have this high telehealth group within the cardiometabolic cohort. And similarly, their utilization dropped from 17.6 to about 15. And you can see here they had higher telehealth utilization compared to the low telehealth group. On average, the high telehealth group had 4.1 telehealth visits and compared to 2.5, and they also had fewer in-person visits, 10.8, compared to the low telehealth group, where the number of in-person visits was 12.3. So there really appears to be a substitution effect here. Like, telehealth visits are not added on top of people's in-person visits. People are really using telehealth to substitute some of their in-person care. And overall, we see that the reduction in ambulatory care utilization was pretty similar between these groups, was slightly bigger for the high telehealth group, but overall pretty similar. So how does this translate to spending? On the next slide, we show change in total spending. So on the left, we have the low telehealth group within the cardiometabolic cohort, and their average spending dropped by about 19%. And for the high telehealth group within this cohort, their spending dropped about 21%. But for the most part, I would say the reduction in spending is slightly larger, but similar. Okay, next we look at the asthma cohort. So we're still sticking with the cardiometabolic cohort for a second. So on the next slide, we break down the spending by category. We have inpatient facility, professional, outpatient facility, and prescription drugs. And here it looks like for every category of spending, except for prescription drugs, spending dropped slightly more for the high telehealth group. And the exception here is for prescription drugs, and we know from prior work that prescription drugs, it's one of the only area where spending actually increased in 2020. Ooh. Hopefully our presentation will be back. Thank you. Okay, so next we'll actually turn to the results for our asthma cohort. So for the asthma cohort, the direction is different, but again, I think we can interpret the reduction in care utilization being pretty similar between the two groups. So for the low telehealth group, number of ambulatory visits reduced by 16%. For the high telehealth group, total visit volume reduced by 15%. So slightly larger for the low telehealth group, but generally similar. And the next slide, we look at spending. And this is directionally the same as the utilization numbers. Reduction in spending was slightly greater for the low telehealth group, 26% reduction from 2019 to 2020. And for the telehealth group, the reduction was 24%. But in terms of absolute dollar amount, about $100. So the reduction is pretty similar. Okay, and then lastly, we look at the healthy cohort. You'll note here that the total number of visits was much smaller for this cohort compared to the two cohorts earlier where folks had chronic conditions. And here in the healthy cohort, the number of ambulatory visits reduced by 5% for the low telehealth group and 6% for the high telehealth group. So again, the reduction is similar in terms of utilization. And then lastly, we look at spending on the next slide. And again, the reduction is pretty similar for the low telehealth group, spending reduced by rounded up 7%. And for the high telehealth group, it's about 7% as well. In terms of dollar amount, the $20 difference. Okay, so all together, I think with these three cohorts, these results really suggest that telehealth use does not increase total spending. And on the next slide, so this has been a long research presentation. I'll just summarize some of the main findings based on our commercial analysis using 2020 data. So in 2020, telehealth accounted for 1/3 of all commercial ambulatory visits. Nearly 2/3 of these visits were for mental health conditions. We observed pretty significant differences in terms of telehealth use by patients attributed provider organization, but few differences by payer. Telehealth use was higher for patients with higher risk scores and those living in more urban communities and communities with better internet access. And there were pretty minimal differences by community income. And based on data just from the last quarter of 2020, cost sharing for telehealth did not appear to affect demand for telehealth. But this is an area that we plan to keep monitoring using 2021 data. And then lastly, we looked at telehealth's effect on total spending, and we find that telehealth use did not appear to increase total utilization or spending. Okay, I will turn it back to Sarah.
Before you do that, I just want to ask a question on this last bullet. When you did the examination of utilization and spending and the low and high, that was focused on non-mental health E&M visits, correct?
This is actually looking at their utilization was looking at all of their ambulatory visits. So any visit that's not in an emergency room or inpatient setting for the most part. And then the spending slides actually includes all of their spending. So if you are someone who is in the cardiometabolic cohort and you had at the same time had a mental health condition, those spending would be counted in there. It's just the healthy cohort probably does not include many people with mental health conditions.
But they were sorted. They were sorted into groups based on the non-mental health utilization of telehealth, because that's where the most variation was. Mm-hmm.
Yeah, I mean, I think you said it nicely. The study suggests that telehealth, these were substantive visits, not additive, in terms of overall visit utilization, and that on a spending level, it didn't appear to increase spending, nor did it seem to decrease spending if you had a higher, we're in a community with higher telehealth use. I guess the point I was getting to, though, is when we look at overall psychotherapy visits, those went up. I mean, so to me, that's kind of clear that telehealth did enable greater utilization and perhaps greater spending on mental health conditions. And we can say that's a very good thing because it was clearly providing needed access. But I wonder if there's a way that we could think about that aspect of it as well.
Yeah, I wonder if we could have a cohort with specifically folks with a mental health history, and we can track their spending from 2019 and 2020 as well, and see whether total spending has changed.
Yeah, I wanted to actually pick up on that just to start off, because it is clear from this that mental health was the key single biggest change. And in principle, we could potentially look for things like patients who complete a full course of psychotherapy, or maybe patients continuing on medication if what you need to do is talk to a mental health professional to get refills of medications, or even potentially things like patients who don't wind up in the emergency department or don't wind up inpatient hospitalized. So particularly for groups that we know we're having difficulty completing mental health therapy prior to COVID, has this made their life be much easier? Has it made it much easier to be able to keep up with mental health care?
We should totally follow up on those outcomes. We could do that very naturally within this framework. It's a great idea.
Let me open it up to Any of the commissioners or anyone else who's here to ask questions, give comments?
We just have a couple more slides
Oh,
that are
I'm
sort
sorry.
of summary points that might help inform.
Sorry, I
discussion.
thought
No,
this-
no, no.
I
That's
love
fine.
this summary here, so I was kind of
More is
keep
more.
it up here.
Yeah. Okay, can you go, yeah, next slide. So we'll just run through quickly some of our early input that we've gotten from stakeholders. We also have a number of other conversations that we're looking forward to having with payer providers, patient advocacy groups. So I just wanted to share quickly some of the insights that we've learned because they're really relevant to answering the questions that we've been charged with, starting with, sort of to inform what the payment level should be relative to in-person visits. We think it's really important to understand, well, what is the cost to the provider of running these robust telehealth programs compared to what their sort of, when I say cost, I mean the practice expense would be for in-person visits. And what we've heard from providers is, like running telehealth programs does not reduce our costs for running our in-person visits. So our total practice expenses have not gone down as a result of running robust telehealth services. And in fact, our costs, their sort of practice expenses have gone up because they still need the same number of administrative staff, they still need the same office space, and now they also have some expenses for the technology aspect. And in fact, in many cases, the clinicians who are providing telehealth are sitting in their office in the facility anyway. So, however, we know that also, while it may not reduce practice expenses, telehealth may increase the total revenue that a provider is bringing in because we know that telehealth reduces no-shows. People are more likely to complete their visit when it's easier for them to do so. However, some payers have noted, well, that might be true that the total practice expense is the same, but hey, the expense of providing a single telehealth visit is often less than the cost of providing a single in-office visit because, sometimes providers are in the office, but sometimes they're in their own homes and you don't need the overhead lights and you don't need sort of all the support staff. So sort of next, what we've heard on access to care and quality of care, we've heard that telehealth has particular benefits of access to care for certain patient populations. That really includes patients with chronic conditions who may have some, they may have mobility issues, they may have transportation needs, and just at the end of the day, they just need a lot more visits. And this is sort of reducing the disruptions to their lives of always needing to go into an office, as well as those who live far from, those whose sort of burden of travel would be farther to get to those in-person visits. Another key question is about, okay, well, what about audio only versus video? Is there a, sort of video? We've sort of heard, video visits lend another depth of patient interaction and may have higher sort of quality from that respect, but audio only visits do increase access for certain groups that may have sort of lower familiarity with technology or lower ability to use technology, such as some older patients who don't have reliable internet due to connectivity in the area or financial barriers to having either the equipment to do so, paying for Wi-Fi, a private room to do a private space to do these visits. So there may be some questions of trade-offs of access to care versus quality and sort of what are the best recommendations to support goals of health equity. So that's, and again, we are planning to have a number of additional conversations. And next slide. This is our last slide here, and this just wraps up some of the key questions as we see them about how should we approach our recommendations on payment parity. Really want to highlight that this is an area that telehealth really fits in very nicely to recommendations that we have made that support the need for increased global payment models. This is really an area where global payment models would really pay dividends to improve patient access, improve transparency for patients, so we don't get into scenarios of, oh, is this doctor, hey, I just got a bill for a 10-minute phone conversation with my doctor. Oh, I thought they were just returning my call. I didn't know that this was a visit. So, when you have a global payment model and you're not paying for each individual service, that really sort of prevents that situation. Policies and clinical guidelines for supporting access and quality of care. We've talked about video versus audio. Facility fees, is it right to charge facility fees for a telehealth visit? This could be a tricky question, although for us, it's sort of not that tricky because we have already recommended strongly to prohibit facility fees for E&M visits, which would sort of include most telehealth services anyway. And then finally, a question we're interested in is the role of third-party companies, such as sort of Teladoc and other alternative models of care. The focus of this report is sort of naturally on services that are being provided by the provider groups themselves, but this is another question that really is a part of the landscape that we're interested in. So with that, we will turn it back to you, David Cutler, for leading the conversation.
Thank you. We have a couple minutes. Let me see. Tim, I see your hand up, so we'll start with Tim, and then if anyone else wants to jump in, please just raise your figurative or real hand. Tim.
Thank you. Really great presentation, and these policy considerations, I don't claim to have any clarity or guidance on those at the moment, but I think those are really important questions for us to grapple with and better understand and come up with some recommendations on. I just had a question about access to care, and maybe, I don't know if this is something that we've looked at, but one of the things I've been thinking about with telehealth as it relates clearly to the workforce shortage as well is the impact on folks who would want an in-person visit versus a telehealth visit, and is it having an impact because there's being, with the telehealth services, I'm assuming it requires more staff, and can you find the staff to do it? But are we seeing an impact on wait times or ability to get inpatient or in-person visits because of the addition of telehealth? Kind of like the reverse of the access issue. Is it stopping potential access issues for folks who need or prefer an in-person visit versus a telehealth visit?
Yeah, I think it's a great question. And it raises the question of, I think, network adequacy also. Like if you count sort of providers who have availability for telehealth only, but have a transportation time that's out of reach for your patient panel, should that be counted as an adequate network or not? So thank you for highlighting that question.
Marty, yeah. Oh wait, Marty, you're still on mute.
Sorry about that. Let me try to answer Tim's question. I'm hearing from lots of mental health agencies that they're losing clinicians to telehealth. So clinicians who would ordinarily have been in the office are now deciding that they can be in private practice, work from home, and do telehealth, particularly in the behavioral health field. I guess I have two questions or comments, and great study. Thank you. One is, are we factoring in the course of the pandemic here? So if we think about the quarters that you showed, we know that there are surges. We know that people may decide, it's a low surge period. I may want to do an inpatient visit versus, thinking about last December, January, where it's a high surge. So I may want to not participate. So how do we factor in just the course of the pandemic? And then my other question is, where do, so those outpatient clinicians that I just talked about, where do they show up if they're unaffiliated with, they'll show up in a paid claim if they take insurance, which hopefully they do, but they don't show up as a provider because they're in private practice. So do those get captured somehow in the data?
Do you want to take that one, Yo?
Oh, sure. So I'll answer the second question. So they, you're right. If they take insurance, the smaller providers, if they take insurance, they are in our APCD, and we, in the results where I showed provider variation, the bar charts, they were not in that chart in particular. That those two charts just show patients attributed to the larger provider organizations, but in the regression results that I showed, those patients are in, and they were sort of all grouped together in sort of this other category of provider organization. And for those patients, if my memory is correct, that telehealth use it's about average for patients attributed to those smaller provider organizations. And your first question about pandemic, it's not something that we have specifically factored in, but you can see in the earlier slide where I showed how telehealth use has changed over time. We could see clearly that once the summer starts and summer rolling into fall, where things, some of the restrictions were lifted, more people returned in person and telehealth visits dropped. So some of that did show up in terms of the volume change for in-person visits versus telehealth use. But again, once we have 2021 data, I think we'll have a better understanding of over the longer term how these trends changed with the dynamics of the COVID-19 pandemics changing.
It seems to me that this was a quite democratizing technology. That is, you used to have to rent office space and potentially be in a bigger group and so on. And now you can kind of be on your own practicing whatever hours you want from your home somewhere or something. And so what may be difficult for the bigger organizations may actually be much better for the individual clinician who now has the choice of practicing at home or practicing in a bigger setting or something like that. So it's unlike many things like EMRs, which sort of push people to join groups. This is something that allowed people to be independent of groups. That may be good or bad, but just a kind of, that seems to be some of what's happened here. These are fascinating results. So on the one hand, just to give one final thought. On the one hand, sort of, it's bad that it hasn't saved us money. On the other hand, it's not. I'm not sure. Right. Like we also know that people are not getting enough primary care visits and especially behavioral health visits. So anything we can do to get people more primary care and behavioral health visits is probably good, whether or not it saves money. And that seems to be what this has done here. So I think, my own personal view is that overall this is good for the Commonwealth, even if you might have hoped it would save money. Maybe it doesn't do that, but certainly for other things, it seems like a very good innovation for us. That may be more of a personal opinion, but that's where this evidence leads me to think about.
Mm-hmm.
David, I'm wondering, we're a little bit behind, but I'm wondering if we should jump to the to the second part of the agenda. Does that make sense?
Yes, that sounds great. And more work to be done on this particular topic, as stated, and look forward to working with this committee and the full board as we prepare the report and consider the really important policy considerations here. Those are some really tricky issues. And of course, it probably goes without saying, we are not alone in Massachusetts in wrestling with these topics. These are national topics that many states are looking at. And so we'll also want to learn from others as well. So let's just quickly shift gears into our next agenda item, which I previewed at the top of the meeting as reflective of our recent cost trends report recommendations, but also other work that we had done this year in examining provider expansion. So I'm going to turn this right over to our MOAT team. I don't know, Kate or Sasha, who's going to lead this, but.
Thanks, David. I think I'll be leading if you can hear me. Great.
Yeah, you sound great.
Excellent. So yeah, as David said, want to follow up today on a couple of the proposed market changes that I mentioned we were looking into at our last board meeting. Those being determination of need applications for significant inpatient hospital expansions at UMass Memorial Medical Center and Boston Medical Center. And as David said, we're circling back to those because they have a nexus with our cost trends recommendations around constraining excessive provider prices. As you know, we've highlighted for years that prices continue to be a primary driver of spending growth in the Commonwealth. And as you recall, the recent cost trends report reiterated our recommendations around limitations on prices and price growth for our highest priced providers to reduce unwarranted price variation and promote quality and community access to care. And in addition, we recommended that the Commonwealth closely examine the potential impacts of major provider expansions, particularly for higher priced providers. And the UMass and BMC expansions sort of give us an opportunity to take a look at how those recommendations fit together. So I want to start though on the next slide. So as you know, certain types of expansions of providers require that those providers file an application for determination of need with the Department of Public Health. And those include major capital expenditures of the sort that we're going to be talking about today. DPH evaluates applications for projects like this based on a set of factors defined in the DON regulations. And those include factors related to the project potential public health value, impacts on access, alignment with community need, health equity considerations, and the ability of the provider to financially sustain the investment. They also include a requirement that the applicant demonstrate the project will compete on the basis of price and other indicia of healthcare spending, and that it will meaningfully contribute to the Commonwealth's cost containment goals. Most DONs, as you know, don't require the filing of a notice of material change with the HPC because usually they don't involve more than one provider organization. The notable exceptions to that being hospital acquisitions, which will always require a filing of both a DON and an MCN, and many joint ventures that involve ambulatory surgery centers or advanced imaging will come across as an MCN regarding the joint venture formation, and then a DON for the services. But as you know, HPC is a party of record to all DON filings, so we receive copies of the applications when they're filed, including things like major provider expansions and where we look at those filings and see that there might be a potential for significant impacts. We take a look at those expansions using all of the tools that we've developed in the provider transaction space, adapting them for an assessment of what we think the potential impacts are going to be on spending and access and quality, for just to make sure that we are all informed of what we think is going to happen with expansions and to see whether we can lend useful information to the DON program as appropriate. So we wanted to share some examples of the sort of work that we've done to look at at these two changes in particular. On the next slide, though, before I sort of launch into our assessment, because we haven't covered these projects before publicly, I want to orient you to them a little bit. This is obviously only a very high-level summary based on the publicly available filings. So let me know if you have questions. The applications were both filed and finalized this summer. UMass first in July and then BMC later. Both, as I said, major expansions of inpatient capacity, with UMass proposing 91 additional beds at UMass Memorial Medical Center, their flagship AMC. It has two campuses in Worcester, the Memorial campus and the University campus, along with a number of renovations and an additional CT unit to support all of that new inpatient service. BMC proposing to add 70 total new beds, 60 med-surg beds and 10 ICU beds, with similarly additional renovations and improvements, expansion of some operating and perioperative space to support that inpatient expansion. These represent a roughly 20% increase in med-surg beds at UMass, and a 15 to 27% increase in beds at BMC. Both projects have pretty substantial spending figures attached. Both hospitals sort of have cited current capacity constraints and expected future capacity constraints as rationales for the projects. And then, in terms of process, DPH hosted a public hearing in August on the UMass expansion. That project is just generally further along in the review. DPH held a hearing, has received a number of public comments, and just issued its staff report recommending the approval of the project with certain conditions this past week. Whereas for BMC, it's still further behind. They are, as I understand it, scheduling a public hearing for the end of October, I think October 28th, regarding that project. And both projects have seen some commentary by Mass General Brigham, which is formed TTGs, and St. Vincent Hospital also formed a taxpayer group to comment on the UMass expansion. Any questions? Again, a very high level summary, but any questions about either project before I roll on?
I think it's just just interesting that overall in Massachusetts, we probably have too many hospital beds. And yet we're still seeing institutions that say they need more. And I suspect what's happening is this is more continuation of people moving from smaller local hospitals into big regional and national, hospitals. And that's sort of the way that the hospital market is trending, which has some advantages and some disadvantages too.
Yeah, I think that's exactly right. And as you know, these proposals are a continuation of a trend that we have seen with other systems proposing new bed build-outs primarily at their flagship hospitals. And as you know, some of it has been around renovation and adaptation of legacy space, but there are also usually significant expansions of beds being proposed. And I agree, you have, I think, accurately described what we are seeing. So on the next slide, as you'll recall, our team regularly uses an econometric model to predict patient diversions. We work with outside expert economists to examine utilization patterns of commercial patients in recent years, looking at which hospitals patients use and examining patient characteristics like age, diagnosis, acuity, and the drive times of patients to the hospitals that they use. And then we can use that model then to predict if a given hospital expands beds and receives more patients, where those patients might otherwise have received care. We use a model based on commercial patients, since differences in commercial prices among hospitals are one of the key factors that drive spending impacts. And we using information about the number of new proposed beds, average length of stay, expected utilization, and commercial mix, we can estimate the number of new commercial discharges that are likely to fill those proposed new beds. You can see for the projects we're talking about in the middle column here, it's around 2,100 expected additional commercial discharges for UMass, about 600 expected additional commercial discharges each year for BMC if the projects go forward as planned. And so then using the model I just described, we can predict roughly what proportion of those new commercial discharges would come from various competitor hospitals. In the right column, you see where those patients would come from in these cases. And I'll note that our model usually uses a sort of Boston and Eastern Mass centric patient sample. We've adapted that for use with UMass here specifically. And you can see that for both UMass and BMC, they're both academic medical centers, and they're both likely to draw a pretty significant proportion of new discharges from other AMCs, including Mass General and Brigham and Women's, because those hospitals, see a lot of patients with similarly high acuity. But also a substantial portion of new discharges would come from other hospitals. For UMass, that includes St. Vincent Hospital, which is a teaching hospital not far away in Worcester from the UMass campuses, as well as various community hospitals. And that's in large part because the most significant factor for where a patient seeks hospital care after controlling for everything else is proximity. It's drive time to the hospital. And there are just fewer hospitals in central Massachusetts relative to greater Boston, and new beds at UMass are more likely to serve patients who would go to other local hospitals. And it's worth noting that includes other hospitals in the UMass system, like Health Alliance, Marlborough, and Harrington, in addition to non-system hospitals like Milford Regional. So you can sort of see the breakdown here. I want to, note that those figures these figures are based on, as I said, patient characteristics and utilization patterns. UMass in its DON materials described efforts to ensure that only appropriate care ends up at UMass Memorial, building out its community hospitals, transferring back patients where appropriate. Those efforts, as we understand it, some of those things have been ongoing for a while, and to the extent that that is true, the results of those efforts are already reflected in the model that we've used. Understanding that Harrington in particular is new to the UMass system, and they've sort of described a number of efforts that they have. I'll flag that the staff report for the UMass DON recommends requiring UMass to provide some annual reporting on each of its system hospitals on staffed bed capacity, occupancy, and patient acuity. And that's the sort of information that would allow DPH, as well as us and other stakeholders, to track to what extent a proposed UMass bed expansion would serve patients that otherwise could have been seen in community settings, to sort of see whether the acuity mix at UMass Memorial goes up or down, and what is true for the community hospitals in terms of staffing and occupancy. So their DON program has been thinking about this question as well. So you can see the mix of where these new expansions are likely to draw commercial patients. The next slide shows how that mix influences spending impacts of potential expansions. So, as providers gain patients, spending impacts are largely driven by two factors. One is sort of total volume of commercial patients, since again, those are the ones for whom differences in negotiated rates can impact spending. And the other is the price of the expanding provider relative to other options and competing providers. This slide illustrates differences in price among hospitals that are relevant to the two projects we're talking about today. The graph is for Blue Cross Blue Shield, since that's the largest commercial payer for all these relevant hospitals. And you can see in the leftmost column of the graph, UMass is in orange, BMC is in green. The other dots in that column represent other Eastern Massachusetts AMCs. MGH and Brigham and Women's are sort of superimposed on each other, since they have about the same price at the top of the column there. You can see UMass's prices are sort of moderately high. BMCs are the lowest among the AMCs. The central column shows price points for other Massachusetts hospitals, central Massachusetts hospitals. St. Vincent is at the top of that column, just under 1.0, the average price for Blue Cross inpatient care. And you can see some other UMass community hospitals there, Health Alliance and Harrington, in a lighter orange, with Milford and Athol down there at the bottom. And then the furthest right column shows all of the other hospitals from which we predict at least 3% of new commercial patients for either of the projects would come. And you'll see that there's an orange dot in that column for Marlborough Hospital, which is a UMass hospital, but not technically in Central Mass, but we figured we would flag that out as well. So I think the graph illustrates pretty well that price differences and the degree of difference matters in this context. To the extent that UMass and BMC can draw new commercial patients from higher priced hospitals like MGH, Brigham, and Children's, which is the topmost dot in the right-hand column, those shifts are likely to reduce total spending. And to the extent they draw patients from relatively lower priced hospitals like Haywood or Athol, spending is likely to increase. And so we combined the mix of hospitals from which we expect the projects would draw new commercial volume with this relative price data for not only Blue Cross, but for all the relevant commercial payers to predict the spending impacts for each of the proposed expansions. We ran a few different scenarios with different assumptions and found that the UMass expansion would probably increase total commercial spending on inpatient care from between $5 to around $6 million per year, given that, again, UMass has sort of moderately high prices relative to others, while BMC's expansion would likely decrease spending by right around $2 million a year because of its low relative prices, particularly low relative to the other AMCs from which it would primarily draw patients. And it's worth noting, we can contrast these assessments with some that we did earlier in the year. You'll recall that we examined the potential impacts of a proposed expansion at Mass General Hospital in exactly the same way. And because MGH's prices are high relative to almost every other hospital in the Commonwealth, and because it has a relatively high commercial payer mix, so the volume of commercial patients that would shift to fill those beds is larger, we found that an expansion at MGH would likely increase commercial spending by between around $23 million to about $40 million each year. And so all of this is an example of the sort of impacts price variation have on our market. As long as commercial price variation persists, it's going to be a significant factor in thinking about the potential impacts of provider expansions. As we discussed earlier, DPH in the DON review is evaluating the potential impacts of these things on quality of care, access, health equity through that review. and policy approaches that would reduce unwarranted price variation would also help to sort of shift some of the focus off of the spending concerns that naturally follow from these price variation, and allow DPH as well as provider systems and community stakeholders to focus on those other important factors that really ought to be the driving decision-making points around how and where and what kinds of services are expanded in the Commonwealth to fit patient need, as opposed to having to worry about whether a potentially beneficial expansion from an access standpoint is going to result in really meaningful spending increases just because of negotiated price variation. So that is the summary of what we put together on this. So welcome any questions or thoughts.
So Sasha, we only have about a minute left or so, but what do we do with these? Do we write something for DPH, or how do we proceed with these?
So as I mentioned, DPH is at different points in its reviews in each of these things. Traditionally we have required a full board vote for issuing a formal comment to DPH. DPH staff, obviously have access to all of these presentations, and we've made ourselves available for discussion with them as needed. But this is all now in the public record, and so we, and I'll say that DPH did make good note about what the price relativities are between the hospitals involved in the UMass expansion. So they have their eyes on this as well.
David Seltz, we've left very, very little time for OPP, but I do want us to turn to it if we can.
Thank you, Commissioner, and thank you, Sasha, for this presentation. I do think it really raises some important questions about the dynamics in our market, the need for additional capacity, and the spending impacts, and how price variation continues to just drive some of these differences in how we might view or think about these. And so I think this was just a brilliant way of highlighting those dynamics. Unfortunately, I think we should move on to the next committee meeting. So we do have a few slides here on an update for the Office of Patient Protection relative to the mental health legislation. And the slides describe our approach to developing some interim guidance for interested stakeholders. We did want to offer the opportunity for them to be able to understand where we are in this process and to reach out to us. So if you're interested in these regulatory changes, ask you to review the slides and certainly can reach out to staff. If by chance we go through the CDT meeting and we do have some time left over, we may return to these slides and do the presentation as this topic does kind of straddle both our committees, and is something that we talk about in both areas. So we may return to this at the end of CDT, but I think for the moment we can close this particular meeting. And thank you, Commissioner Cutler.
All right, thank you, everyone. And with that, we will be adjourned.
So Commissioner Blakeney, I think we can move directly into the next meeting.
Okay, thank you, David. It cannot be said that we don't have strong endurance. This is a marathon. For those of you who are joining us as observers, who were participants or observers in the last meeting and are staying on to do this meeting, I congratulate you on your endurance, and I welcome the commissioners to join for this session. First thing we're going to do is we've called the meeting to order formally, and we'll review the minutes. So those of you who have reviewed, please, if there are any additions or corrections, please Please share them.
A motion to approve?
Thank you, Marty. I don't know that we have a quorum.
We do.
We do. Okay, it's been moved. Is there a second? I guess I'll second it. All those in favor? Oh, sorry. David, please go ahead and call the roll.
We'll start with you, Commissioner Blakeney,
Aye.
Commissioner Cohen, Commissioner Cohen.
Oh, aye. Sorry.
Thank you. And Commissioner Peters.
I think I'm going to abstain because I believe I was only able to make it for a very small portion of this meeting. So we'll abstain from these minutes.
Okay, thank you, Lauren. I believe we have enough to declare the meetings accepted as posted. We have a good agenda today, and without further ado, and in order to take advantage of all of our time, I'm going to turn the meeting over to Kelly, who will be introducing our folks from South Shore. Kelly.
Thank you so much, Commissioner Blakeney. Good morning, commissioners. I'm happy to be here with my colleagues from the Healthcare Transformation and Innovation team to bring you an agenda that I hope provides some concrete examples of work in support of the policy recommendations from the most recent cost trends report. We will do our very best to move through this agenda efficiently, so we have time for our friends in OPP to cover their material. But it is, I hope, a rich agenda for all of you. Our first agenda item will give you a firsthand look at how one of our investment program awardees is using HPC investment funds to respond to the challenge of improving access to behavioral health services, in this case for caregivers and infants experiencing the effects of substance use disorder. A key feature of that program, in fact, in a feature of all of the C4SEND programs, is a recognition that to achieve the greatest impact, we must complement increased access to behavioral health services with access to appropriate community-based social services to address health-related social needs, which is, as you all know, a key theme of our policy recommendations. So following that agenda item, Vivian Hemme will share an update on important work at the Quality Measure Alignment Task Force. As some of you probably recall from Vivian's past presentations, there have been considerable efforts underway for some time now to integrate a consistent set of quality metrics into payer contracts, something that is absolutely consistent with our policy recommendations around improving primary care and reducing administrative complexity. So Vivian will share where we are in that effort and introduce important new work that's been done to develop data standards and accountability for collection of data around race, ethnicity, and other features that will allow us to understand disparities and ultimately work towards our policy goal of advancing health equity for all. And finally, Catherine McLean will build on that theme by sharing work we're doing to collect nuanced patient experience data in a manner guided by the perspectives of individuals and communities, which is again aligned with our commitment around health equity. So as I said, I hope this is a rich and interesting agenda for you. And with that, let me turn it over to Becca Schwartz to introduce our colleagues from South Shore.
Good morning, everyone. My name is, do we have slides? Can everyone see them? Okay, great. All right, good morning, everyone. My name is Becca Schwartz, and I'm a program associate on the Healthcare Transformation and Innovation team, working on the cost-effective care for caregivers and substance-exposed newborns program, also known as C4SEND. I'm joined today by my colleagues Julie Paul and Amir Rayad, who will discuss their programs supporting pregnant and parenting people with behavioral conditions and substance use disorders at South Shore Health, one of the C4SEND awardees. Before I pass them the metaphorical mic, I would like to take a few minutes to give some context about the C4SEND program. The C4SEND investment program is a continuation of the HBC's previous work in behavioral health and perinatal care spaces. Based on the findings from earlier programs and recent research, we recognize the importance of providing comprehensive care and supports to birthing people and substance-exposed newborns, specifically during 7 to 12 months postpartum, when there is a higher risk of overdose for the caregiver that unfortunately coincides with the time around when some supportive services end. With the support of the legislature, we were able to award grants of up to $300,000 to 5 hospitals across the Commonwealth. Next slide, please. Each of the 5 awardee hospitals are using C4SEND grant funds to either establish a net new initiative or expand existing program offerings to address the unique needs of caregivers and their substance-exposed newborns. These initiatives meet the 5 core components of the C4SEND program: providing support for at least 1 year postpartum, coordinating medical and behavioral health care services, including evidence-based treatment like medication for opioid use disorder, providing care free of stigma and bias, supporting caregivers and infants with health-related social needs, and ensuring connection to early intervention. The 5 core components listed here illuminate the ways the C4SEND program advances the HPC's vision and follows the recommendations set out in the 2022 Cost Trends Report, particularly through the program's focus on addressing caregiver and infant health-related social needs and improving access to behavioral health services. Next slide, please. Program implementation began late last year, and we are now over halfway through. We will be receiving the 2nd set of data reports and our 4th program update from the awardees in the coming weeks, and are eager to continue learning from what they share. We've also been working closely with our partners at JSI Research and Training Institute to execute the patient experience evaluation at each of our awardee sites. It is through all this work that I've been fortunate to work with Julie Paul and Amir Rayad at South Shore Health. Next slide, please. Julie is the director of the Perinatal Behavioral Health Program, which she founded in 2018. The program has since grown to include caring for individuals with mental health and substance use disorders throughout pregnancy and up to 3 years parenting. Julie was instrumental in applying for, receiving, and implementing the C4SEND grant, which has significantly expanded services for individuals in the SHORE program. Her professional goals include providing safe care for women with mental illness or substance use during pregnancy and postpartum, safeguarding birth options for women by protecting the birth process, educating women about childbirth and being able to advocate for themselves, and lowering the cesarean birth rate. Amir Rayad is the program manager of the Perinatal Behavioral Health Program and the Bridge program at South Shore Health. He has worked alongside the leadership team to continue to grow the Perinatal Behavioral Health Program and support the receipt and implementation of C4SEND grant funding to provide multidisciplinary services to patients in the SHORE program. I'm eager for you all to hear from Julie and Amir today. Their tight-knit team has been an absolute pleasure to work with, and it has been deeply inspiring to watch and learn about the incredible work they've achieved and the patients they have served so far. They have done a remarkable job keeping health equity at the center of their work, seeking to improve access to behavioral health services for their eligible caregivers and address their needs, both within and beyond the 4 walls of the hospital. Without further ado, I'll give them the floor.
Good morning, everyone. And I just want to take this opportunity to thank Becca. She has been a dream to work with and for inviting us to share our experience with the HPC today. The grant has been transformational in helping us care for our population. So as Becca said, I am the director of the Perinatal Behavioral Health Program. I am both a midwife and a psych NP. I started working in Massachusetts approximately 17 years ago, where I learned that there is a lot of mental health and substance use disorders that go untreated. So my goal was to get more information. Within 1 month prior to even going down this lane of becoming a psych NP, I had 3 women that were 6 weeks postpartum that had suicidal ideation, and I had to send them to the emergency room. That just felt so ineffective and wrong. So I made it a mission to increase my knowledge base, and I decided to go back for my psych NP. During that time, I'm like, okay, so when I get this degree, what am I going to do with it? So simultaneously, I also went for the Duke Johnson Johnson Leadership Fellowship, and that required South Shore Hospital to give me the opportunity to start a program. So I had their commitment right after I graduated from my psych NP in 2018 to start this program. And as you can see, we started the Perinatal Behavioral Health Program in October of 2018. Next slide, please. There are two arms to the perinatal behavioral health program. There is the behavioral health side and our SHORE program. SHORE stands for Supporting Hope, Opportunity, Resilience, and Empowerment. And that is the arm of our program that cares for women with substance use disorders, as well as alcohol use disorder. 80% of my program is the behavioral health side, and we care for pregnant and postpartum people with behavioral health needs, depression, anxiety, bipolar, whatever that might be, those requiring medication management. In the past, historically, there's been a huge need for perinatal behavioral health due to the lack of services for perinatal individuals with behavioral health and substance use disorders. And most programs that are out there are geographically undesirable for our population. There's also a general discomfort in prescribing to this population. Add to that the plethora of misinformation with medication management. So I started this program in an effort to try and reduce some of those disparities and level set and allow women to have the opportunity to have proper information when making decisions. So we started this program in October of 2018, and I was the only provider that started this. I was doing it 2 days a week, and then gradually the program grew to where I needed additional help. And with the help of Self-Shelp Hospital and generous donations, we were able to increase our program. To date, we now have a staff. We've gone from a staff of 1 to a staff of 11, and we currently care for about 450 people on our behavioral health side and about 50 SHORE patients. Now, that number does fluctuate based on disengagement and re-engagement in care. Next slide, please. This slide can be a little bit sobering. As you can see, based on this is taken from the NAS dashboard or neonatal abstinence syndrome dashboard that's available to all Massachusetts residents. And as you can see, Southeast Massachusetts has the highest NAS rate within the state. Also add to that 1 in 7, sometimes the research can be as much as 1 in 5 women struggle with postpartum mood disorders or anxiety disorders. And we all know that pregnant individuals with substance use disorders do experience significant barriers to prenatal care. And as I discussed earlier, there have been a lack of care and resources for women in this area, specifically SUD and pregnant women. The closest programs are often in Boston or in Rhode Island, and it can be geographically undesirable for our patients to leave their community to get the care that they deserve. Other things that I've noticed is that OB providers and general psych providers are often uncomfortable prescribing to this cohort of individuals. There's a lot of misinformation, and pregnancy, postpartum, and parenting are often the times when they need the most support in med management. And then you add a national pandemic to the mix, and the numbers increase significantly. So when the pandemic started in 2020, the majority of our patients were being seen in person. We had to pivot into 100% remote, and that was brand new to our hospital as well as to this clinic. But adding telehealth has significantly increased access to our program for women with substance use disorder as well as mental health. We're reaching women across the state from the Cape and Islands all the way to Western Mass to the North Shore and even on the Rhode Island border. So that has been a really good accomplishment from the pandemic. I was asked to say who our typical SHORE patient was. Well, there is no typical SHORE patient. Anybody can have a substance use disorder. But what we do currently see in our program is the majority of our clients are Caucasian. Many are employed, but most have some insurance. But there is a lot of domestic violence, housing and financial insecurity, as well as DCF involvement. Most families are struggling finding daycare, as well as employment that allows them to work from home so that they can care for their children. Next slide, please. I've alluded to some of the barriers to care, but pretty much a lot of them are access to care, transportation, bias and stigma, insurance, ability to pay. Also, the insurance that most people have doesn't have adequate reimbursements to keep a program sustainable. A lot of women or individuals that come to our program have a bunch of comorbidities, including anxiety, depression, schizophrenia, bipolar. A lot of them have a strong trauma history, add pregnancy and lactation and legal problems, and it makes it difficult for women to access care. Next slide. This slide does have a lot of words on it, but the takeaway I want you to understand is the main objective is to meet the individual where they're at. be it in their recovery, their family situation, their living accommodations, or their mental health. Our program strives to put the individual at the forefront as a major contributor to their care. And we do this through harm reduction in collaboration and introduction to community resources. Next slide. The meat of our program is the SHORE curriculum, and we do this through the different topics that we'll discuss one by one. The first is psychopharmacology. We treat with medications for their comorbidities, for both their substance use disorders as well as their behavioral health. We put clients as their experts in their own body, and they are equal members of our treatment team. They're able to make the decisions that's what's best for them. May not always agree with our options, but they are kind of the drivers in their own care. We also have care coordination. Through the HPC grant, we have been able to add this position. This is a net new position, and it is a midwife who helps us bridge the gap between addiction and OB. She collaborates with the OBs to ensure that prenatal care and addiction care are in alignment to make sure that our clients do not fall through the crack. This person also, Rita is her name, leads our interprofessional group, which consists of our OB providers, neonatologists, pediatricians, maternal fetal medicine, our outpatient OB staff, anesthesias, RNs, and women with lived experience. She also helps create birth plans and pain management plans so that gap doesn't get dropped in the hospital. She educates our RNs and OB providers on addiction medicine. She coordinates our doula program for our pregnant and postpartum clients. She also helps with birth reviews to help reduce traumatic birth and help them feel more comfortable with the birthing experience. She minimizes bias and stigma between the hospital and the clinic. Recently, she had a client express concerns about their hospital stay where they felt stigmatized. She was able to hear the concerns and reach out to the parties involved and bring awareness as well as change. Another big part is our case management. Recently, we did lose our case management manager, but in the past, she also helps with concrete supports in times of need. A lot of women need the SNAP, DTA, CHAMP, transportation, DCF services, and health insurance. She was working with them to understand nurturing and attachment with their newborns. She had extreme knowledge of parenting and child development with early intervention referrals. She helps them with social connections, parental resilience, and then child and social competence as assessed through the Ages and Stages questionnaire, where we partner with United Way with their DRIVE program to get both our results for the state as well as our own so that we can help women bond with their children in the best possible way and to make sure the kids are getting what they need. It also helps with the referral to the early intervention. We had just rehired in this position. That person actually starts this week, so we're very excited to replace that position. We also have an LMHC who's helping with counseling, and she helps our clients develop their treatment plans, plans of safe care, crisis management, distress tolerance, motivational interviewing, and soon we'll be adding EMDR to help with process past traumas. As you can see, every one of these categories helps to wrap our clients in services to make sure that they don't fall through the cracks. We've also added relapse prevention groups to help with harm reduction, Narcan and overdose prevention, and peer support. We've added alcohol use support groups. And then another HPC added is our doula support groups run through First World Doula, which is a group that's out of Marshfield. They help with our parenting support groups, working with moms and dyads, the mom and baby dyads, to help with infant massage, quieting a fussy baby, or peer support, breastfeeding and chest feeding support, as well as labor support with our doula. So the doula will actually go into the women's for their labor and help support them during their labor and birth to help them have a voice when they feel like they don't have a voice. And then we're adding peer support. We just hired a peer support person that starts this week as well. So we're very excited to add that position to our team. Next slide, please. It's also important to highlight the successes. And in the short time that we've been running SHORE program, we have had significant successes. Our first one is BSAS licensure, which we obtained in 2022, which allows us to run our relapse prevention groups, provide alcohol support groups, but it also, more importantly, helps to provide structure for the program. We've had the interprofessional team development so that we can increase awareness within the hospital, decrease bias and stigma, and wraparound support for our clients. In 2019, John and Eileen Graken donated $10 million to provide addiction services for people on the South Shore. They were generous in allowing our program to be part of this And that has allowed us to move into this beautiful office space, which makes patients feel extremely comfortable. We have parking and we're adjacent to the hospital, as well as next to a bus station terminal. We also have aligned with community resources, our local therapists, First Steps Together, Dove, DCF, early intervention, and our local PHP and IOP programs. And finally, we are the recipients of the HPC C% grant, which has been instrumental in helping us transform care. And at this point, I'd like to hand the mic over to Amir so that he can kind of discuss the HPC and how it has extended our program and helped us continue to help our population. Thank you.
Thank you very much. Thank you all very much for having us here. Thanks for listening to our presentation. So yes, my name is Amir and I am the manager of the program. And in the interest of time, let's move on to the next slide, please. So everything that Julie mentioned has started from the bottom and has gotten us to where we are here. So my job as manager is to kind of ensure that we have the day-to-day operations, but also kind of make this sit home with the rest of the organizational leadership team. So as you can see on this slide, we've been able to make a difference in the lives of, over 1,100 unique individual patients. And if you think about it, it's, these are moms, these are our moms, our daughters, our sisters, our colleagues, our friends, our neighbors. We really, to humanize it a bit and to say, what is our short population? It's anyone and everyone that you guys encounter on a daily basis. You never know who's in this program. We've had some incredible success stories and some really tough, heartbreaking stories as well every day. So, it's a team-based initiative. But this kind of gives you highlights some of the numbers and the statistics rather behind it. And then also a big shout out to Julie, who's kind of navigated through a pandemic, through a lot of fiscal constraints, organizational challenges, the bias and stigma that we had internally, as well as externally, that we made a lot of pushes to kind of to improve upon and to increase education have been incredible. So a big shout out to Julie for putting this out there and really getting our organization to dive really deeply into this. Next slide, please. So obviously, as Julie mentioned, a lot of these components are aspects that the C% grant and the HPC has allowed us to really invest in. We kind of knew what we needed for our patient population. We knew what we needed to make sure we were making the appropriate strides and to achieve the successes. But it also allows us to really meet the patients where they're at. It's a mantra that you hear a lot in this organization and a lot within our program. Everyone's going to have a very unique outlook as to what they want to get out of treatment, what they want to get out of care. It's not always going to be the same. It's not always going to be abstinence or going to be completely stopping whatever substance or alcohol that they're on. We really have to meet them where they are, figure out what each individual wants us to, what would like from us. They're the most important member of this care team. And with all of these individuals, whether it's the case manager or the OB care coordinator or the doula support, people they even meet in their groups, all of the above, all of these things that the C% HPC grant has allowed us to invest in, they've really helped to make patient-based care and wraparound services, as Julie mentioned. The data collection piece has actually been quite fascinating, and me as a kind of like a data guy, I find it great to kind of have a subset of information that we can compare to the other awardees. I think it's great for us as an organization to kind of see what strides we're making, so it's less abstract and more concrete. It's really been great to bring to different levels of leadership, as well as for us to kind of see the impact that we're making on a daily basis. Sometimes it's nice to have that little bit of a reminder within the work that we do. So yeah, next slide, please. So the big thing that we have to think about is, we get the grant and it provides us a lot of resources, but we also have to think, what do we do with it in order for sustainability to be a key factor within what we do? And so one aspect that you can always use and translate is the education. So we've really tried to invest heavily in our staff to increase their own professional understandings and kind of continue to further their own education as a whole. So our LMHC has gone through EMDR training. We've had one of our prescribers went through an entire motivational interviewing session and seminar within a course. Julie went through a perinatal loss conference out in the Midwest and brought that back to the team. We had one of our MAs who's going to get certified in lactation support, really so we can ensure that we're giving every single patient who comes into our clinic all of the support that we could possibly provide them. We've also started a lending library where we can provide workbooks to moms to help them kind of understand what they're going to be going through. And it's a lot to take in a short visit with the prescribers and with the LMHCs. So sometimes having that at home and being able to read through it and sift through it and just maybe share that with a spouse or a parent or whoever might be their support cast. It's really helped us and kind of making sure we can get to the individual patients in whatever way they learn. We give a lot of supplies for our shore clients, which has been incredible. So anyone who's pregnant, they get a pack and play for safe sleep space. They get a diaper bag and diapers and a pacifier and Earth Mama Angel Baby butt balm and nipple cream and noise canceling headphones, like about $150 worth of stuff that these moms are so incredibly grateful for. And it's something that we're able to provide them that they don't have otherwise. Sometimes it's just things that they just don't think about necessarily with everything else going on in their lives that we're able to kind of just provide them. We're also able to provide them transportation. One of the biggest barriers that Julie mentioned is individuals just have a real hard time to getting to appointments. I think that's, again, the big proponent of telehealth here is as we think through this, we can get people here who need to come here, whether that be for different kind of, UDSs or whether that be for face-to-face visits, so we can kind of sit with them and fill out paperwork or work with them as to whatever they might need. Well, we have the ability now to get them transportation to their appointments. But for those who don't have to necessarily come, the telehealth has been huge. Next slide, please. So again, as we think about the whole aspect of sustainability and thinking beyond just what happens during the grant, there's a lot of things that we need to continue to improve upon, both in our organization, but as well as within our community. It's really huge that we continue to improve on the OB collaboration, whether that's spreading the word of the services, whether it's increasing screenings, whether it's increasing education, both to their staff and our staff about what services are provided, how to ask the questions, how to navigate the questions, maybe what to look for and at when you're with patients, making sure that the biggest thing prescribers don't want to do is ask a bunch of screening questions and not have anything to not have a way to handle what's being asked. So it's really providing that support to all of our local OB practices and to our organization, to our birthing unit, to whatever it might be, to make sure they are put in a position to succeed, as well as allow our department and our program to continue to grow and flourish and succeed. From a community perspective, it's just the expanded care management and case management for further collaboration. I think what's huge is, we can't be the only player that's working to navigate these same goals, and we're luckily not. There's a lot of other organizations within our community that we can partner with and we can use to kind of take the lift for some of the aspects. Like it's clearly shown in some programs that when you have a one-source shop for everything, that there's a lot more engagement, that there's, the patients are more willing and likely to continue to enroll in those programs, engage in those programs, and remain throughout the duration of the program. However, we also can't necessarily do all of the above. So whether that's the OB has to do the prenatal care, we can do the mental health and substance use care. They can go to some of our organizations like South Shore Peer Recovery or Aspire colleagues. We can leverage a lot of what we have. So that's continuing to build those relationships and to have those actually exist are going to be huge. And so a lot of this is really key as to what we try to do. Next slide, please. So kind of where we go as a whole, there's a big push that we have to continue to address the stigma, the bias, the discrimination that exists within this population. I mean, I think it's still incredibly stigma-based, a lot of bias, and we're doing everything we can to reduce some of those barriers, to really bring the educational component out, to humanize the process. I think that, being very careful of the verbiage and the words that we use and pushing that is going to be huge. We have to reduce the barriers. There are a lot of transportational issues, housing issues, food issues. We do the best we can to kind of meet the patients where they are and kind of reduce some of those barriers, but that's a huge aspect that continues to be a challenge for all of us working in this world. As I said, we're not all going to be able to be the saviors for every single patient. So we really have to be able to spread the wealth and understand who is best positioned to help with different aspects of this patient's care. The big aspect of reimbursement, right? Insurance contracts and virtual visits here. I know the administration has pushed for parity. It's pushed for continuing to reimburse at the same levels of medical care, so that behavioral health is not, put behind the 8 ball right off the bat, right? These organizations and these programs don't exactly flourish financially. So we really have to push and push and push to make sure everybody understands there's no reason this should be any different than a patient's hypertension care, their COPD care, their CHF care, their diabetes care. This is a vitally important and integral aspect of everyone's life. And we need to continue to show that. So I think the administration has made some significant and incredible strides. I think there's more work for everyone to do with that. So parity is huge. I think the advocacy as a whole, is huge too. We have to advocate for a population who's oftentimes been marginalized. They've been kind of seen as the cast-offs. And I think we need to do a lot to really be able to push their voice and push their experience and help everyone understand what that is. And then inevitably it'll increase efforts to promote safe care. It'll allow more and more individuals to seek the help that they might really need, and not feel shamed or not feel like, that they're going to be treated in a certain way accordingly, which is really important. So yeah, I think that all of that's there, and it's something that we're really trying to focus on, and we all have some work to do. And then the other thing, just from a telehealth perspective, I'll say is that's integral for us, because that's increased engagement, it's increased enrollment, it's allowed us to make a more robust program. As we look at virtual visits and we look at how that's going to be paid in terms of parity there, I think that's going to be huge for us as we continue to grow as a program, because we're really making a big difference in a lot larger of a community. But if that were ever to be taken away, I think the organization and the state would see some significant impacts with that. And then, a lot of what we do is, from a cost perspective, like a cost benefit perspective, right? You look at this and it's a lot of what we do is ensuring that the patients are coming to the right setting. They're receiving the most appropriate care by providers who specialize in this type of care. It allows them to not go to the ED, because so many of our patients, if we didn't exist, they'd be calling their OBs, and their OBs may not be well set up to succeed in treating the patients with some of these conditions and their substance use disorders or their mental health conditions and diagnoses. So it's really ensuring that people who have the appropriate training and can really sit with patients and spend the time and have team-based, where like we have our nurse, our MAs, our LMHCs, our prescribers, all of which can kind of sit with that individual and really help them get through the challenges and struggles they are getting through. That's really what our cost benefit is, that you may, there's a lot of value in that. And I think across the state, we're seeing the push for that. So yeah, next slide, please. That is it from our perspective. These are just some references that we have here. But I guess what I'll say is I'll open it up to questions, or however you guys want to do this, Becca, in group. But thank you very much for listening to us and allowing us to provide you with a little bit of a glimpse to our day-to-day and what our program does.
Amir and Julie, thank you both very much for a encouraging presentation. I'm impressed with the truly interdisciplinary team that you put together, responsive to the needs of your individual targeted population. Not many people know how to care comprehensively and well to a population that is this complex. And so I congratulate you on putting together a team with the skill set to know how to do that. Let me open it up now to questions from our commissioners.
I'll just echo your comments. I mean, the level of integration that's been accomplished here is really extraordinary. So congratulations. I guess one question for me, and I think, Julie, you said this early on in your presentation about the importance of community resources. So, and I'm thinking, as folks sort of graduate out of your program, is there an adequate supply of services in the community to meet the needs of moms and babies as they move back out into the community?
I would like to say yes. I mean, there are programs, but a lot of the programs are inundated with a lot of people because, as you know, substance use disorders are prevalent throughout Massachusetts, and they end up getting lumped in with other programs where they're just another number. There are great programs out there, don't get me wrong. It's just we're lacking some of the resources where they're so used to being wrapped around and cared for. And even when the kids are young and 2, 3, 4 years old, when they're released from our program, the family still needs a lot of support. And to create community resources that support that is really a need that I believe that still exists in the community.
And we've had, part of this has led to the discussion as to what is our time frame from our program, right? Is it 2 years? Is it 3 years? There's other programs who do similar work where it's 1 year. So it all comes back to, if we want to make sure that we can do that high touch component of care for the duration of where the patient really needs, where mom really needs that support. So that question we actually struggle with today, there to this day. There's a lot of great people doing a lot of great work, but I don't know if there's a place that can take on all of the ask that we provide or that we have with our population.
Okay, thank you. Other questions?
Sure. Thank you, Julie and Amir, for this great presentation and all the work you're doing here. With respect to the integration, on the multidisciplinary integration, that feels like it is a critical component of your work here. If you were to sort of give one piece of advice to another provider organization looking to replicate this program, from a workforce standpoint, what is sort of the one piece of advice you would give to ensure that level of multidisciplinary integration, knowing that various trainings and skills have historically been fairly siloed between medical, behavioral health arenas. So just helpful to understand, how do you think about building that workforce to really support and promote that integration of multidisciplinaries?
Great question. And I think it really revolves around realizing that you can have great people, but you can't just, one person is not going to make a difference. Like, you have to be able to share the wealth a little bit. This is a very challenging population to work with, but it's also one of the most rewarding things I've ever done. So realizing who's around you, what else can you get from community supports and members of your team, and what can they bring to the table to make this a better experience for the individual with mental health and substance use disorder. Everybody's got a family member or a friend who is struggling with addiction or mental health. And this, what we've learned is it can affect anybody, lawyers, doctors, like nobody's immune to substance use disorder or mental health concerns. So how can we make our world, actually your community, a better place for everybody? Is you got to unite, come together and not practice in silos, and bring your team together, because everybody has something. And especially our members with lived experience, making sure they have a seat at the table, because they're the ones who are dealing with the conditions and what it's really like out there. So hearing everybody's voice and kind of coming together with the idea that we can make this better for our community as a whole, because these are young moms and young families, and these are our children that are going to be growing up to lead our government officials or be our police officers or our teachers. So how can we support this family in a way that helps the entire community grow?
Julia and Amir, a couple of questions from me. You mentioned, Julia, in your response to Lauren, your consumers having a place at the table. What does that look like in your program?
This is newer for us. So we're recently just hired somebody with lived experience. She will be joining our interprofessional team, just being allowed to sit at the table and represent, like, what is it really like when you're trying to access care in the community, or go to the grocery store, or take care of your kids. Like, we can imagine it as much as we want, but actually have somebody with that experience bringing that to the table. So we know that we're not doing things that feel good for us, but we're actually doing something that make an impact for the people that are actually experiencing what's going on in their community or in their life or their own hardships. I can only imagine. I don't have lived experience myself, and I've designed a program based on what I think, but what do the people really need? That's really what we need to hear from, their voice.
And when we think about this position a little bit, they're going to have a seat at the table of the interdisciplinary meeting. They're going to be involved in all of our staff meetings, but they're also going to be involved in some of the processes and improvement efforts that we make as an organization. As we start thinking about our service line beyond just this just our short program, their voice, their value, their expertise are going to be a huge aspect and component to ensure that we can really resonate with our population and that we can really relate to them, because it's tough to put yourself in their shoes without now we actually have somebody who's been in their shoes.
My commissioner colleagues will know that I say this quite a lot when I quote Don Berwick, who says about patients, nothing about me without me. Meaning that programs are wise not to go too far down the road without ensuring that the people with that lived experience participate. So I congratulate you on hiring somebody who comes to the table. And I'd like to encourage you to, when you're ready, take another step forward, which is that you have something like 1,100 patients who have now gone through your program. There might be a time and a place to consider creating a community advisory board, which allows multiple people who have actually gone through your program to advise you about your program from their lived experience. So when you're ready, I would encourage you to seriously consider that. And please know I do this with all of our programs. I encourage all of them at the appropriate time to move to do that. As a former community organizer focusing on health many years ago, I learned if I didn't listen to my community and understand what they needed as opposed to what I thought they needed, that I would be in very deep trouble and very isolated very quickly. So I encourage you to, when you're ready, to consider doing that. My second question is more about measuring your outcomes. This is the kind of program that's very difficult to measure benefit over time, not only in terms of what you see with individual patients, but what and how do we measure whether there is a community benefit, whether there is a financial benefit in the work that you do. And we know that the patient population is very complex, which kind of guarantees to me that the measurement will be very difficult. What are you thinking about that?
I'll take the first part, but then I'm gonna let my data guy take the rest.
Okay.
But what I can say is data I get that I find the most valuable is the stories, like what's actually happening in the patient life, because these are, as I described earlier, these are individuals with their children that are impacting the entire community. So are they able to get a job and be successful? And are their kids going to school? And are they doing well in school? Are they getting the support when they're parenting to be able to parent successfully so that the children have a fighting chance? So that's how I view the success. How successful are they within the community to be able to continue to get what they need and then give back to their families and the community in general? So from that perspective, that's how I measure the success of the program. Like, how well are you actually doing? And when they stop coming back, and I know that they're doing well, that's kind of the biggest reward possible. It's not the thank you card, it's seeing them not come back and really access the community, the resources, the jobs, and that their kids are doing well and they go on to have a second pregnancy without needing our services. That to me spells success. Now from the data guy.
No, I say this to all our HPC colleagues a lot with like Becca and Catherine and Molly. The hardcore numbers are a component of this, but they're not. That's really hard to show what this program does just through numbers. So the stories are really the huge piece, but stories don't necessarily suffice for a lot of components. So from our perspective, we do a lot with volume, retention, enrollment. There's a lot of data there. I think from an outcome perspective, standardized screening tools, this could be a challenging conversation, but I think standardized screening tools can help provide a little bit of insight into the difference we're making in all of the lives of our moms. Some of those standardized screening tools can assess, we do a lot of them at the initial intake, and we kind of figure out, how do you feel? How are you doing? Whether it's the PHQ-9, the GAD-7, the protective factor survey, we have a whole array of things that we actually do. And we get a baseline as to where the patient is at that individual moment they come into care. And then we do that again at the termination of care, whether they've either been transitioned to another program, they've decided that they're just going to disenroll at the present moment. We really try to kind of tidy it up to a degree and assess, what have we done? Have we actually decreased some of the barriers that you've had gone through? Have we improved your mental health? Have you improved your substance use aspect? Are you actually seeing a therapist? Are you actually now engaged in MOUD treatment? There's a lot of components where if we can ensure that they're, even with the babies, do you actually have a pediatrician now? Are you actually seeing a pediatrician? Are you going to your well child visits? We look at all of these components behind, the actual life of the individual, the mom, as well as their babies that come into this program. And we kind of assess and look at our benefits and our outcomes in that regard. So both at the caregiver level, at the baby level, and then programmatically at a, obviously we look at things from volume perspective, we look at things from a financial perspective, we look at things from a employee retention perspective. There's a lot of ways you can look at this, and we kind of divvy it up and have our COO and CEOs really kind of harp down on different minute aspects within that. That's a long-winded answer. I mean, not all of which probably are what you were looking for necessarily, but that's kind of what we decided to do. But we're also part of a larger service line. So I want you to understand, like, we also have a lot of outcome measures that we're continuing to figure out and work with our senior leadership to figure out what might be best to try to track, knowing that there's a challenging group of patients to track.
Exactly. Exactly. Which is why I want to encourage you to continue along those lines, but continue to be creative in terms of thinking of what a measurement looks like, whether we like it or not. Healthcare is under incredible financial pressure to be as efficient and effective as possible. And we have to be able to demonstrate cost effectiveness. In addition to the lived experience, which we all value a lot, how do we demonstrate to those who look at the financial picture that there's a financial reason to continue the program, as well as an ethical and moral reason to continue the program? So I just want to extend to you and your program a hearty congratulations from the commission. I think we're thrilled with what we've heard from you today. Julie, I congratulate you on deciding that you, as a midwife, you needed to be a psych NP. Congratulations. I don't know too many people who just decide to go back to school and pull that off. Well done. And we look forward to your continued success and hope that we continue to hear from you in the future and hear great stories and great outcomes from you. So thank you very much for spending this time with us.
Thank you.
Thank you very much.
Take care. We now have the opportunity to move on to our quality measurement and alignment group. And Kelly, why don't you frame that up for us?
I think I've said all I need to say at the beginning of the presentation, other than to just say that this has been really important work that I know Undersecretary Peters has been deeply involved in, and others. So I think it's the work around the health equity recommendations, I think, is a really important step forward. And we're anxious to share what's going on. So let me hand it off to Vivian.
Wonderful. Thank you, Kelly, and good morning, commissioners. As Kelly mentioned earlier, I'll be providing an update on the work of the Quality Measure Alignment Task Force, and I'll be covering a couple of topics today. The first is an update on payer adherence to the Massachusetts Aligned Measure Set, and the second is an overview of the work of the Health Equity Technical Advisory Groups. So as you may know, Massachusetts has been engaged in a voluntary process of aligning quality measures with the goals of reducing administrative burden on providers and payers and focusing quality improvement efforts on high priority areas. This process began in 2017 when EOHHS convened the Quality Measure Alignment Task Force to make recommendations on an aligned measure set for voluntary adoption by Massachusetts payers and providers in their global budget-based risk contracts. As Kelly mentioned, the task force is chaired by Undersecretary Peters, and since its inception, the HPC has served on the task force, provided staff support, and has also funded expert facilitation for the task force by Baylor Health. Next slide, please. In order to track adoption of the measure set on behalf of the task force, CHIA and the HPC issue the Quality Measure Catalog Survey on an annual basis, by which payers report the measures included in their risk contracts for the subsequent year. As you can see, overall adherence to the Massachusetts Aligned Measure Set has improved in the last several years from 65% to 85%, but payer adherence remains variable. And I'll also note that when we exclude Mass Health from this analysis, overall adherence by commercial payers is only 78%. The task force and the interagency staff that support it continue to explore ways to promote adherence to the aligned measure set in the absence of a legislative mandate. We plan to collect this data again in the next couple of months for 2023 contracts, and we'll plan to report back at a future CDT meeting. Next slide, please. I'll now switch gears and provide an update on the health equity efforts that the task force has undertaken. As I shared last February, when the state reopened its biannual procurement for new members last summer, EOHHS added a specific goal tied to advancing health equity. I should note, though, that even before this became an explicit goal of the task force, the topic of health equity measurement has always been part of the discussion. Additionally, I should note that around the same time that this became an explicit charge of the task force, Baylor Health issued a survey on behalf of the task force to ACOs and payers in the Commonwealth to understand the state of data collection for race, ethnicity, language, and disability status. Through that survey, we learned that most providers and payers are collecting race, ethnicity, and language data, although the standards they are using vary between and sometimes even within organizations. Additionally, only about half of organizations are collecting disability status, and the existing data that we have is often not self-reported, which is the gold standard, and rather is based on patient observation or imputed based on other data elements, such as patient zip code. So this work was an important step in realizing that there's an opportunity to improve data collection across organizations. And as most organizations are actively engaging in efforts to improve their data collection systems and to use data to identify and address inequities, there's really an opportunity for alignment across payer and provider entities. Next slide, please. So while it made sense to position this adjacent effort under an existing alignment effort, we certainly needed to engage individuals with different subject matter expertise than those serving on the existing task force. For this reason, EOHHS convened 2 additional health equity technical advisory groups. The first to advise on health equity data standards for the collection of social risk factor data, including race, ethnicity, language, disability status, sexual orientation, gender identity, and sex. And the second to advise on an approach for introducing accountability for reducing inequities. QMAT Health and the HPC jointly funded the facilitation of the 2 new health equity technical advisory groups, which were also facilitated by Michael Baylor and his team at Baylor Health. Before I share the outcome of this work, I want to note that both groups include a diverse representation that combines subject matter expertise, operational experience, and lived experience. The groups really brought an incredible breadth of knowledge and perspectives, which resulted in really robust conversations. I should also note that, to our knowledge, this is a first in the nation effort to achieve consensus and alignment on health equity data standards. If we're able to implement these across payers and providers in the Commonwealth, our ability to identify, measure, and address health inequities experienced by residents of the Commonwealth would be markedly better. Next slide, please. So the health equity technical advisory groups kicked off their work last February and met monthly or more through this past June. Over the course of 7 meetings, the data standards technical advisory groups developed these recommended standards for the collection of social risk factor data. Some of the principles that they considered in evaluating data standards, including their ability to roll up to federal standards, how well they reflect current terminology and best practices, and ensuring that options were inclusive but not exhaustive, and that they're representative of the populations in the Commonwealth. The standards that the group recommended are listed in this slide. I won't go into details about all the standards they considered and why they selected each of these, but I will bring a couple of things to your attention. First, as you see, the data standards group opted to include a granular ethnicity category, noting that the existing race and ethnicity categories did not fully capture or reflect some important subpopulations represented in Massachusetts. The group recommended using the Massachusetts superset because it builds off of prior state initiatives and was designed to reflect the Massachusetts population. For those that aren't familiar with it, the Massachusetts superset was developed by the Brookings Institute for the Department of Public Health following a 2007 state regulation that mandated all acute care hospitals in Massachusetts collect ethnic background data. And it includes approximately 30 main ethnicities such as Somali, Cape Verdean, and Brazilian, and 140 additional sub-ethnicities, which roll up to the OMB race and ethnicity categories. For the capture of disability status, as well as gender identity and sex, the data standards group recommended the Oregon Health Authority standards, which build on federal standards in some really important ways. Just to give one example, for the collection of disability status, the OHA standards add 2 questions to the US CDI version 3 standards, which ask about developmental disabilities and disabilities related to mental health conditions. And so the data standards group really felt that those were important groups to capture. In order to validate and refine some of the questions included in the OHA standards, the BELA team contracted with Massachusetts Health Quality Partners to test the wording of questions with a diverse sample of patients. Based on findings from these cognitive interviews, as well as expert opinion based on their decades of experience administering surveys, Massachusetts Health Quality Partners made recommendations on wording for some of these questions, as well as for the non-response options. And all of those will be reflected in the final Health Equity Technical Advisory Group recommendations. Next slide, please. I'll now turn to the accountability group, which was charged with developing a recommended approach for introducing accountability for health equity measures into global budget-based risk contracts. The group developed a set of 8 principles for health equity accountability, only 2 of which are reflected on this slide. Importantly, the group proposed a framework with 4 main categories of health equity measures. While the first 2 categories introduce accountability for improving the collection of self-reported data and the use of that data to identify inequities, the third and fourth categories introduce accountability for the reduction of known inequities. And then within each of these categories, there are also multiple measure concepts. So as is listed in the principles, accountability can be introduced for multiple types or categories of measures simultaneously, but measures should be implemented in a stepwise fashion. What this means is we don't need to wait for 100% data completeness to begin holding providers accountable, for example, for screening populations for their health-related social needs, or even for stratifying the data that they do have. That said, within each category, we can't introduce, for example, performance targets without first having the ability to stratify the data and understand the disparities in the data. I don't think I'm able to do this work justice in the 20 minutes that I have, so I really encourage you all to read the recommendations from these groups, which are available in draft form on the task force website and will be available soon in their final form. Additionally, the BELA team that supported the facilitation of this group published a health affairs piece in March that details the accountability framework, and it's titled A Typology for Health Equity Measures. So that might be another good piece to add to your reading list. Next slide, please. So here I provide an overview of the process for the Health Equity Technical Advisory Groups. As I mentioned, they kicked off their work in February and each met 7 times. In June, their recommendations were shared with the task force for additional input, and they were then posted for public comment in July. 18 organizations or individuals submitted public comment, and at the September meeting, the task force reviewed the public comment and provided input into the recommended approaches for incorporating all of that feedback. The final Health Equity Technical Advisory Group recommendations, inclusive of all of those changes and edits, will be posted and disseminated to Massachusetts providers and payers in the coming weeks, pending approval from Secretary Sutters. Next slide, please. So as we think about next steps and the implementation of these standards, the Health Equity Technical Advisory Groups and the task force identified a number of ways that state agencies or others might support providers and payers in the implementation process. Some of these include provision of technical assistance for staff training and consumer education around the importance and use of social risk factor data, technical assistance on the data standards implementation into data systems, methods to centralize or facilitate data sharing between payers and providers to avoid sort of the patient burden of having to report these data multiple times, to multiple organizations. convening a group to update the Massachusetts superset, which I mentioned was developed in 2007. And all of this is constantly evolving. So there's definitely an opportunity here. And then convening peer learning sessions with providers and payers for them to share implementation challenges and best practices as they engage in the implementation of these new standards. And here on this slide, I've also posed a couple of questions for your consideration. And at this point, I'm happy to do my best to answer any questions that you may have. But before I do, I want to once again acknowledge the participants of the Health Equity Technical Advisory Groups, including my HPC colleagues, Leiden Marcelot and Mike Stanek, our colleagues at CHIA, DPH, and Mass Health who contributed to this effort, and of course, Undersecretary Peters for her leadership in this work.
Thank you. Lauren, is there anything that you would like to share from your leadership position?
No, I think Vivian really covered the waterfront here. I think that it's been a really sort of exciting process to have this initiative. My understanding is first in the country, and is fairly, it's really the only effort to align and across both quality measures, but also with folding in the health equity pieces. My understanding is that no other states are doing this, and really appreciate all of the work collectively that the various state agencies, as well as all of the stakeholders that have come to the table. I've been really impressed by the commitment and engagement by payers, providers, and various stakeholders to this process, and I'm confident that it will yield the outcomes, and the recommendations are truly reflective of that. So nothing sort of new to necessarily add, other than just express my appreciation for all of the effort that's gone into this work.
Thank you, Lauren. And it's clear that Vivian could spend another hour and still feel as though she just touched the surface. And Vivian, I thank you for what must be always frustrating to try to grab the very top of the outcome and share it and give us a clear sense of how much work went into it and how deeply engaged in the work and the data that you all have gone. So are there other questions for Vivian? Well, Vivian, your questions for the commissioners. How could the HPC use its levers to support adaptation of the recommendations? How would you like us to proceed with that? You're asking the question, but I think you might have some thoughts.
Yeah, I mean, I think these bullets at the top, I think, present some ideas that the groups had for how state agencies might support implementation. And, we do have some levers at the HPC to possibly support in some of those areas. And so, really looking to you to see if some of these, jump out at you. Certainly, convening peer learning sessions with providers and payers to share some of the challenges and best practices is, within our convener ability. So that might be an area we might explore, but are there any others that jump out at you as areas that we might explore supporting?
Mm-hmm. Great question. Thoughts from our commissioners?
I think continuing to present this information on a regular basis is going to be important, and particularly those that whose participation in the overall set of quality measures is not as high as it could be. So that's one area where I think we could use our bully pulpit to get greater participation, and continuing to focus on the equity measures is really so important. I commend the task force for what you've done. I mean, this is really incredible.
Commissioner Blakeney, could I just add one additional thing, which is
Sure,
in terms of in terms of the levers that the HPC can apply, we actually applied a fairly significant lever in the cost trends recommendations, specifically, calling out the opportunity to align around the health equity recommendations for the coming from the quality measure alignment task force. So hopefully that will, that's to Commissioner Cohen's point about using our bully pulpit, that certainly was a significant one, and hopefully we can continue to build on that as well.
I also suspect that given the broad engagement of multiple agencies to create this document, that a coordinated approach among those agencies to continue to keep this this material and this report front and center in every venue where it's appropriate should be coordinated and should be continually developed and reported back on across agencies. This is a cross-agency effort, and I think that keeping it on the forefront and using it in multiple venues as appropriate is a cross-agency coordinated effort. So I would encourage that while the report is complete, that the effort to implement it and to expose it to the avenues and groups that need to hear it is a continuing coordinated effort among the agencies. And so I would encourage that. And Lauren, under your ongoing leadership, I suspect that sits most comfortably with you. But as an ongoing effort, I think our continued coordination with this is critical. David, any thoughts?
I would just want to highlight and the context of these recommendations as well with the recently approved waiver. The waiver, really centers health equity as a really important goal. It is truly, I know you throw around first in the nation a lot, but this is truly a nation-leading design in the Mass Health ACO program. And so I think the context of rolling out with the new waiver, these recommendations, our opportunity to update our ACO certification program in the coming years. And, this last year was this round of certification. We put more health equity focus into our certification standards and questions. I think those will continue to evolve. And so I completely agree, Commissioner Blakeney and Commissioner Cohen, both using our bully pulpit, using our cost trends recommendations, as a blueprint that we hope to advance with the new administration and the new legislature, being able to work across state agencies and also to work with other organizations outside of state government, like the Health Equity Compact, being led by Michael Curry and others that are really trying to create a broader framework for health equity improvement in Massachusetts. So extremely timely, and the really kind of technical and difficult work of doing all of this will pay dividends in the future, I have no doubt. So thank you, Undersecretary Beers and Vivian as well.
And I'd also suggest that we keep our eye open for possibilities for publication. This work needs to get out there, and I think timely publications in the right places at the right time would do a lot to benefit. So Vivian, thank you. Lauren, thank you for your leadership in this work. Let's keep this on our front burner, and let's continue to refer back to it. And David, I know you and the staff will help us reflect back on it as you see opportunities to put it in the various working material that we have before us. So thank you all for that work. I believe our next item on the agenda is the evolution of the patient experience. So Kelly, let me give it back to you.
Yes, and I'm gonna quickly hand this off to Catherine McLean, who has said she will move swiftly, so we can hopefully leave some time at the end for the OPP agenda item. So with that in mind, I am going to turn it over to her.
Thank you, Catherine.
Yeah, thank you very much. Good afternoon, commissioners. As Kelly mentioned, I'm Catherine McLean. Very happy to be talking to you today about the current approach that we're taking to the evaluation of patient experience in investment programs. This approach is applying to the two current investment programs for which HPC is the primary evaluator, CFRSEN and BESIDE. For a little bit of background, we just wanted to present an overview of the evaluation approach of our investment programs, of which the evaluation of patient experience is one part. In terms of the mission of our evaluations, we're really focused on whether, how, and why our investment programs achieved their goals. And we really emphasize a mixed methods approach, combining both quantitative and qualitative data, because we believe this provides a more holistic picture of the program. And then you can see also here the evaluation framework, which consists of 3 parts: implementation, impact, and sustainability. The questions asked in each of those areas, which you can see on the slide, help us understand the working of the program, the impact it had towards program goals, and whether there are actionable results that they scale or sustain beyond our investment program term. These questions also serve as guideposts for developing program-specific evaluation questions based on the aims of each program. We really feel that the evaluation of our investment programs contributes to an important body of knowledge about care delivery change, implementation efforts, and provides important accountability for the results of our investments. Next slide, please. So this slide covers the role of patient experience in our program evaluations. We believe very firmly in the role that patient experience plays in the delivery of high quality healthcare and the role that positive patient experience can have in driving patient engagement and overall health. I think we heard great examples of the importance of centering patients in care that's delivered from our colleagues at South Shore from the CFRSEN program. And ensuring the voices of patients are represented is very critical to knowing whether the care delivery models truly achieved their aims. And that feedback is also an important part of fulfilling our health equity commitments and understanding whether we have achieved equity goals for the program and whether there might be more to be done to work to reduce inequities in a given area of care delivery. Our CFRSEN and BESIDE programs in particular lend themselves to this aspect of patient experience because of the populations that they are working with and the aims of the program, which I will get to in just a moment. Next slide, please. In general, we do try to tailor aspects of the patient experience evaluation to the specific investment program. But for the CFRSEN and BESIDE programs, we did decide on some common aspects that would help address the specificity of our goals around patient experience in both of these programs. So in both programs, we're using both surveys and interviews to capture breadth and depth of patient experience. We are also particularly interested in experiences of inequity and discrimination, as both CFRSEN and BESIDE have goals centering around understanding those inequities. We went through a procurement process for both investment programs separately and then awarded a contract for the patient experience evaluation work for each. Both contracts ended up going to teams from John Snow Research and Training, Inc., or JSI, a well-known public health consulting firm with expertise in research and evaluation. Next slide, please. So as I mentioned, this current approach to patient evaluation applies to two of our programs. I wanted to give a little bit more detail about each program. So our cost-effective care for caregivers and substance-exposed newborns investment program, or CFRSEN, has a program aim of improving the quality, efficiency, and access to care for substance-exposed newborns and their caregivers. You heard a great deal about one of our awardees in this program at South Shore earlier in this presentation. There are 4 others for a total of 5 awardees in this program. On the other side of the slide here, you'll see 2 evaluation questions. For our investment program evaluations, we generate a number of evaluation questions that are specific to the goals and aims of each individual program and fall under the implementation, impact, and sustainability framework that you saw earlier. Here you see 2 of our evaluation questions for the C4SEND program that will most directly be answered by the patient experience data. We're particularly interested, again, in the experience of stigma, bias, and discrimination that can be faced by individuals with substance use disorders in accessing healthcare. And we're also interested in the patient's perspective on how they see the impact of the program affecting them and their families in the long term. Next slide, please. And now for a bit more detail on the BESIDE program, which stands for Birth Equity and Support through the Inclusion of Doula Expertise. The aim of this program is to address inequities in maternal health outcomes and improve the care and patient experience of Black birthing people by increasing access to and use of doula services. There are 2 awardees in this program. And as with the C4SEND program, we've generated a number of evaluation questions for BESIDE. And on the right, you can see 3 of our evaluation questions that the patient experience data will be used to answer. We are very interested in the experience of trust and respect because we know that Black birthing people and Black people in general accessing care in the healthcare system can often experience distrust and instances of disrespect within the healthcare system. And we're interested in the impact that the support of the doulas has on that experience. We're also interested in the sense of safety and agency as challenges with being able to have a say in their own care have been well documented in terms of being some of the root causes of maternal health inequities for Black birthing people. And then we're also interested in what ways did working with a BESIDE racially concordant doula impact patient experiences broadly and specifically in relationship to a patient's healthcare team. So what was the impact of the doula on the whole healthcare team and the experience of the patient who was at the center of that team? So in addition to presenting a little bit on the 2 programs, we also want to highlight a unique feature of the BESIDE patient experience work. Next slide, please. So as I mentioned, we tailor our patient experience evaluations to the specific program. The question areas and topics that we're focusing on in each program are slightly different as our approaches to recruitment. But one other difference that we really did want to highlight is in BESIDE, we are making use of a patient experience committee. The team is convening this group to inform the evaluation. So this committee will consist of doulas from both awardees and past patients in the Birth Sisters program at BMC, an expansion of which is being funded by the BESIDE investment. This committee is a concept that comes from the participatory research framework and built naturally on the goals and intent of the BESIDE program as it centers the lived experience of doulas and Black birthing people in addressing maternal health inequities and improving patient experience. The role of such committees is to ensure knowledge and lived experience and expertise of the populations who are participants in and subjects of the research is centered and reflected in designs and conclusions. And this can be especially helpful when there is not concordance between the researchers and the population so that any bias or misinterpretation can be avoided. You can see some additional details also on the slide about the structure and facilitation of the committee. Next slide, please. All right, so currently we're in the fairly early stages of this process. There are many steps to developing the evaluation and getting all the way through to interpreting and delivering the results and findings. So as you can see from where we are in these 2 timelines, somewhat early days, but we do expect to begin data collection in the coming months, continuing through the end of both of these investment programs next summer. And then we look forward to sharing some findings with you once we have completed the project. Next slide, please. And then this final slide has some reflections. While we're engaged in this approach to patient experience, we're actively trying to capture what we're learning and reflect on how we might apply that to our approach for future investment programs. The first being critical to start early in this process that reflects not only our experience, but some feedback from awardees about what would be helpful to them. Throughout this process, we've tried to be very attentive to ensuring an inclusive process, and we've learned a lot along the way about things such as reading levels for populations, language access needs, and also thinking carefully about when we're asking participants questions about potentially sensitive subject matter and what kind of considerations and support need to go in there. Next, the procurement process. As I said, we have great teams from JSI working with us and have found them to be quite aligned with us in equity and inclusivity considerations, and they've worked within their organizations to provide some opportunities for language, cultural, and racial concordance for our participants with regards to the staff. But this work has really emphasized how central all of those things are in quality patient experience work that is respectful of the patient populations. And we really intend to take this forward in future procurements and think about how we can build on the ways we're embedding health equity into our evaluation and patient experience work. And then finally, there has been a bit of a learning curve in working with some of the hospital IRBs, different policies and procedures. But I think we've learned a lot that we'll be able to carry forward to future efforts in this area. So that concludes my presentation today. I want to thank the CFRSEN and BESIDE teams, our contracted teams at JSI, our evaluation and investment program colleagues who've been a part of this effort, as well as our leadership team for their support. I'd be happy to take questions or comments you have at this time, but I know we may also be needing to move right along so we can squeeze in our OPP colleagues. So thank you very much.
Catherine, thank you for a wonderfully concise and effective presentation. We appreciate it. I know there's more to come on these programs and on the evaluation piece. Are there any questions? Catherine, hearing none and having heard the presentation from South Shore earlier today and the work that they're doing, I have no doubt that both of these programs continue to do outstanding work. So thank you. And David, I can happily turn this meeting back to you and give you a little bit of time.
Great. Thank you, Commissioner, and thank you, Catherine, for that great presentation. And thank you, Commissioner Blakeney, for carving off a few minutes here at the end of this meeting, at the end of this 3-hour marathon to return to this topic on OPP and appreciate the opportunity just to quickly highlight this because this is going to be a regulatory process that we're going to undertake over the next couple of months. And important to make some of this information public so that interested stakeholders can participate in the development of the regulation, because we are going to need to revise our regulations for the Office of Patient Protection. So Hannah, if you can bring back up the MOAT slides on this section. And just by way of introduction on the next slide, the impetus for revisiting the Office of Patient Protection regulations is recently signed legislation and act addressing barriers to care for mental health, sometimes called the ABC bill, which was a comprehensive legislation passed by the legislature and signed by Governor Baker in August. We've presented an overview of the many different ways that this bill impacts the HPC's work, and we're just going to highlight today, as shown in this kind of orange box, that the law does require us to update our regulations and the protections and processes that the Office of Patient Protection provides to residents of the Commonwealth. And so that is the process that we are undertaking. So I will quickly turn it over to Nancy Ryan, who is the director of the Office of Patient Protection, just to highlight the areas in which we're going to have to make some updates and our proposed approach and timeline.
Thank you, David. Thanks for making some time for OPP during this meeting. This first slide just gives an overview of OPP's core duties as a reminder to commissioners and the general public. The new mental health law amends OPP's duties as they pertain to regulating the internal grievance process, processing external reviews, and also a little bit related to our consumer assistance and information. If you want to go on to the next slide. This gives an overview of the changes in the new mental health law that amend OPP's duties. In that first row, the law amends health plan responsibilities relating to the internal grievance, or also called the internal appeals process. One change in the law, for example, mandates that health plans respond to internal grievances by certified or registered mail or other method with proof of delivery. Another change in the law related to sort of internal processes at health plans is that health plans have additional duties related to mental health parity when developing new medical necessity criteria. Regulatory changes are required for OPP to implement this section, as our current regulations mandate, the processes around internal grievance and also medical necessity criteria development. The second row gets into the changes to OPP's external review process. For example, relatedly, the law makes it explicit that OPP process requests for continuation of coverage in non-expedited reviews, as we currently only process continuation of coverage requests during expedited reviews. And in instances where the health plan does not meet the internal grievance timelines and doesn't provide that sort of newly required proof of delivery, the external review at OPP must be ruled in favor of the patient. It's necessary for OPP to update regulations as our regulations outline the necessary requirements for the external review process. And we also plan to develop interim guidance to give people an idea of sort of how we are addressing this immediately. And I'll get into that on the next slide. But the last row here sort of goes into OPP's role in mental health parity compliance at the state level, and really codifies some of the referral and identifying trends work that we already do with our state agency partners. And there is a new requirement for the Division of Insurance to consult with the Office of Patient Protection when they complete mental health parity market conduct examinations. So we're, in the process of sort of discussing these new requirements, discussing our new role related to mental health parity with our state agency partners. And the next slide goes into a little bit more about the interim guidance that we are developing. We are developing this guidance to notify health plans and also sort of the broader public consumers about OPP's implementation related to the external review process in compliance with the law. The interim guidance will be effective from November 8th, 2022, which is the effective date of the law, through the issuance of final regulations, which we hope to release in the spring of 2023. There's some key areas we hope to address in the interim guidance. The first is that we sort of effectively plan to allow additional time past November 8th for carriers to meet that proof of delivery requirement that I spoke about on the last slide. And in the interim guidance, OPP hopes to detail what it will accept from health plans to sort of meet that timeliness requirement, so that we have substantial evidence to know they're meeting that timely notice requirement just in the interim while we are sort of finalizing our regulations. And under the interim guidance, we also hope to make it known that we'll process those requests for continuation of coverage on non-expedited reviews, and we also will give further guidance on sort of review of medical records and other sort of changed language in the statute. And the last slide just gives a detailed sort of proposed timeline for the regulatory changes. As I said before, the law takes effect November 8th. We hope to bring to the board in January of 2023 proposed regulations. We'll have a public hearing according to sort of the regulatory process that's laid out by the Secretary of State. We will have a public comment period through March of 2023, and then again bring to the board sort of the final regulation and hope for a board vote to issue that final regulation in April of 2023. So we really hope to move expeditiously and wanted to sort of take this opportunity to let the public know about the interim guidance that we're planning and sort of the market changes that are afoot.
Wonderful. Thank you, Nancy. And we look forward to continuing to engage with commissioners as we revisit this regulation and strengthen some of these standards and processes per the legislation.
Okay. David, I think with that, we've concluded. Thank you, everybody, for the marathon session. Hope everybody is enjoying the nice weather. And we will meet again when Kelly tells us we will. Kelly, when is that?
I believe after the first of the year.
Okay. Well, and thank you very much, everybody. I hope you have a very good